4, 3, 2, 1. We are live, sir.
Hello, good evening, everyone. It's a great pleasure to welcome you all for this current Oncology Update Series 5. It's with great pleasure. It's a pleasure to invite Dr. Rajat Bajaj, a Senior Consultant Medical Oncology, Fortis Hospital, Noida, to start the proceeding. But a great news, Dr. Rajat, congratulations for being selected as the Indian Achievers Award. So congratulations to you, sir. These are 2 days quite excellent, day 1 and day 2. The day 1 is absolutely focused in updates in GI cancers, and day 2 will be focused into lung cancer. It's also a pleasure to have the organizing team, Dr. Chaturbuj Agrawal, and of course, Dr. Venkat from Assam Cancer Care Foundation. So looking forward to you. Dr. Rajat Bajaj, sir, over to you with your opening remarks, sir.
Yeah, thank you. Am I audible?
Yes, sir, you're absolutely audible.
Yeah, good evening, everyone. I thank everyone for joining this evening for this current oncology update series on GI and lung cancer updates. We are running this series over the next 2 days, that is today and tomorrow. Today, we are going to discuss all the updates that have happened in the last few months in the GI oncology, and tomorrow we are going to talk about the lung oncology updates. As all of us will agree that oncology is a branch which is very evolving, and we as clinicians and oncologists have to keep abreast with all the upcoming scientific data. And of course, with the ongoing pandemic, we can't really vouch for the offline meeting, but we have to really keep ourselves attuned to what new is going on in the all over the world as far as the oncology is concerned. And for that very thing, we have organized this meeting. My colleagues, Dr. Chaturbuj and Dr. Venkat, will also be here in some time, and we have tried to focus on what all we can discuss in the next 5 to 6 hours over a period of 2 days as far as the GI and lung is concerned. I thank the team of Mr. Mathur for organizing this meeting, and I will set the ball rolling by inviting Dr. Kinjal Jani. Dr. Kinjal Jani is the head of the department in the Department of Radiation Oncology at HCG Ahmedabad, and Dr. Kinjal is going to talk about the role of adjuvant radiation in curable gastric malignancies. Dr. Kinjal, over to you.
Thank you so much. Good evening, everyone. Am I audible?
Yes, you are audible.
Okay, thank you so much. So I'll start sharing my screen. First of all, I'd like to congratulate for, arranging this kind of a meet where everybody would be learning a lot of new things which is happening. I'll try to be as brief as possible and not try to bore you a lot. As we all know, the role of radiotherapy is decreasing day by day in the management of gastric malignancies. So I'll try to be as crisp as possible so that, people are not bored. Okay, so first of all, I'd like to thank my colleague, Dr. Samir. Dr. Manish is my friend from Indore, Dr. Viraj, and my colleague, Dr. Vega, for helping me with this presentation. We all know surgery is the mainstay of treatment for gastric malignancies, but it does require pre-op, either a pre-op or a post-op treatment, as only surgery is not enough, and the death rates are around 50%, which were quite high earlier. And in the last 20 years, we have seen we are doing something new things, and the results are getting better, but still not a very promising sight. We all know that we have been shifting to neoadjuvant setting. My talk is on the adjuvant role of RT in stomach, but let me just start with the neoadjuvant setting. And if you talk about GI malignancies, because today is a topic of GI, we know that we have moved from adjuvant to neoadjuvant in most of the sites of GI, starting with esophagus, gastroesophageal junctions, rectum, or a locally advanced borderline resectable pancreas, where these are the conditions where we give preoperative radiotherapy with chemotherapy followed by surgery. And in stomach, we do a perioperative treatment in the form of chemotherapy mostly, and in some selected cases we use radiotherapy also either in the pre-op or the post-op setting. So why do we need NSCT or NSCT-RT? Because we want to get a R0 resection and a good local regional control as well as the distant control. And to improve that, we have been shifting to neoadjuvant chemotherapy or a neoadjuvant chemoradiation. And at the same time, we have to make sure that the patients tolerate the treatment well, so that we can have a better outcomes for this patient. Now, if you talk about GE junction tumors or gastric tumors, all the medical oncologists would agree that this was a trial, which changed the guidelines. FLOT. In the FLOT 4, 44% of the patients were gastric cancers. And here, we have started giving perioperative chemotherapy. Means you give chemotherapy before the surgery and you give it afterwards. And you saw the result. You saw the result that, giving the FLOT, the results improved significantly. The p-value was statistically significant compared to ECF. The median overall survival was 35 months, which changed to 50 months. And R0 resection with FLOT came to around 85%. But the compliance was a bit issue. The Indian patient did not tolerate it very well. So people are using modified FLOT for a selected group of patients. And when you talk about the trials which are going on for the esophagus or the stomach or the GE junction tumors, these are a few trials which I found. And, I'll just focus on the gastric ones. You see the Top Gear or a Critics 2 or a PREACT. These all trials, you can see they are comparing the CT versus followed by surgery, followed by CT, versus chemo, followed by chemo radiation, followed by surgery, followed by chemo. Similarly, here it is CT followed by surgery versus CT followed by CTRT followed by surgery versus chemo radiation followed by surgery. And PREACT, it is chemo, surgery, chemo radiation, surgery, chemo. So, a lot of trials are going on for the role of radiation in stomach and GE junction tumors preoperatively. So we don't find too much of studies nowadays for adjuvant radiotherapy for stomach tumors. But now, as my topic is for the adjuvant, let me go into adjuvant. Now, this was a trial which set the ball rolling. The INT0116 McDonald's trial. It was published in NEJM 2001, where for R0 resected gastric adenocarcinoma, they were randomized to receive either 5FU-based chemotherapy followed by chemo radiation, followed by further 2 cycles of chemotherapy, or observation. And here, if you see the results with the chemoradiotherapy arm was better than the surgery arm. But here, the problem was, this was an earlier thing. This was published in 2001. So we are talking about patients taken in the 90s, where the D2 resection was quite less, 10%. And right now my surgical colleagues are so expert, they usually go for a D2 resection. But in that era, the majority of the patients were in the D0 or a D1 resection. So maybe that was one of the reasons patient had a very good response to chemoradiotherapy afterwards compared to chemotherapy alone. Now extending this further, this was again the continuation of the INT0116. In JCO 2012, this was published that, there are different things. But if you see the D level, for a D0 and D1, it was better to go for an adjuvant chemoradiation compared to a D2 resection. And the interstellar variant of the histology of an interstellar type of gastric carcinomas did comparatively well compared to the diffuse type in this study. And if I can show you another one, if you compare this, if there is a D1 resection and if you see surgery, there is a very high chance of local recurrence. Whereas if you add chemoradiation, the chances of recurrence are quite less. But if it is a D2 resection, it is almost similar. And if you see the survival, again, not too much of a difference, but yeah, chemoradiation was a bit better than the surgery alone. But whereas in the D2 resection, it was almost equal. Again, I found this study from Italy, where they showed no improvement in overall survival or a disease-free survival, even after adding chemotherapy or a chemoradiation in a D1 or a D2 resection. But this was a very small study. Now, this was an interesting study. This was an artist study, which was published in GCO in 2015. It was a phase 3 trial comparing the adjuvant chemotherapy with capecitabine and cisplatin versus concurrent chemoradiotherapy in gastric cancers. And in this study, what was found, this was very interesting. If you compare both the arms, the survival was not too much of a difference. The p-value was 0.09. But in one particular area, when the nodes were positive, adding adjuvant chemoradiotherapy did better than adding only chemotherapy in node positive. Whereas in a node negative, there was no much difference in both the arms. So artist study showed that for a node positive, adding chemoradiotherapy was better than adding chemotherapy alone. Now, again, this is another study, artist 2, ESCO 2009, in which there were 900 patients with a D2 resection. Stage 2 to 3, lymph node positive, were stratified, and they are randomized to receive adjuvant chemotherapy with S1 for 1 year, or you take adjuvant chemotherapy with S1 and oxaliplatin for 6 months, versus adjuvant chemoradiotherapy, where you give 2 cycles of SOX followed by S1 plus radiotherapy, and the further 4 cycles of SOX. And the primary endpoint was disease-free survival. And if you see the outcome, the disease-free survival, the DFS was almost equal for both the group, means the chemotherapy, SOX or the SOX plus radiotherapy. They were both the similar ones. But you compare it with the S1, these two were quite better. So DFS was better, around 78 to 73% at 3 years for a chemoradiation arm or a chemo arm, compared to 64% for a S1 arm. Again, to subgroup, if you see it in a subgroup, if you compare the S1 versus the chemo RT or chemo, it was definitely better. But if you compare the chemo RT versus chemo alone, there was no statistically significant difference. It was a 0.4 p-value. So that this trial showed that there was no advantage of adding adjuvant radiotherapy for a D2 resection patients. Again, another study of critics, which was in Lancet 2018, they had randomized patient to receive 3 cycles of neoadjuvant chemotherapy, followed by surgery, followed by either 3 cycles of chemotherapy, or you receive adjuvant chemoradiotherapy. And in this critic study also, there was no benefit of adjuvant radiotherapy. If you see the forest plot, not significant difference between both the arms. And you see here, chemotherapy alone group was a bit better than a chemoradiotherapy group, maybe because of the chemo used along with chemoradiotherapy was a bit less intense compared to only chemotherapy arm. But this all studies were with conventional radiotherapies. The older studies were with conventional radiotherapy. Now, in the recent era of IMRT and ICRT, IGRT, and the recent era, by that I mean like last 15 to 20 years, where we have started using IMRT, we can deliver the dose more conformally, sparing the normal tissues. So even in a D1, D2 resection, if you add IMRT, they were better than the only conventional radiotherapy. So this was a study of a 68 patient, again a very small number for a D1, D2 resected patients. They added the chemoradiotherapy again with the trial like INT 0116, but with the IMRT. In the original INT 0116, it was 3D conformal radiotherapy, and in this study, it was a IMRT. Again, the course was exactly the same, and here they found the 3-year disease-free survival was significantly better in the chemoradiotherapy group compared to the only chemotherapy group, which was 56% versus 29%, and overall survival was again better, 68 versus 44%. This is again a very interesting thing. It was published in Journal of Cancer in 2019. How do the patient of stomach fail? They fail either loco-regionally, or they have a peritoneal metastasis, or they have a distant failure. If you see, you are not only worried about the distant failure. Here it was a patient of 1161 patients, where 29% had a distant failure, which we are definitely worried about. A 24.5 had a peritoneal, but a 22% had a loco-regional failure also. So there is definitely a role of local treatment as far as the management of gastric cancers is concerned. And adding the radiotherapy, you prevent a local failure. And with the newer techniques, you do a very conformal treatment, spare the normal tissues so you can deliver a proper dose which is required, and spare the normal tissues, which was maybe lacking in the previous days where you could not give proper dosage. The routine dose what we give for gastric carcinoma is around 45 to 50.4 gray adjuvantly with a 1.8 gray per fraction, so which comes to around 5 to 5.5 weeks of treatment. And if there is a R1 dissection, we add a boost to that particular area. We may go up to 54 gray or 59.4 gray. And these are the areas where we avoid radiotherapy too. So this was something which was missing in the 3D conformal era, but which we can now do it very well with the IMRTs. So if you talk about adjuvant radiotherapy, the trials have shown that the intestine type of gastric carcinoma do a bit better with adjuvant radiotherapy. RT study showed that a positive rate of lymph nodes involvement was independent prognostic factor, and the patients who had node positive, they did better with chemoradiation. And there are other studies also which show that the N ratio, if they have more than 25% of the node positive, they do better, 55% compared to 28% if the nodes are less number of nodes are positive. Now to sum this up, I'll just show you the NCCN guidelines of 2021 and 2022. It is exactly the same. If you see here, what we do, so majority of a patient falls into this category. So we usually have a patient in our clinic which is CT2 or higher with any kind of nodes, and they are usually fit patients. In this scenario, we go for a perioperative chemotherapy. That is a preferred choice. So this is what is proven now, that we go for a perioperative chemotherapy. In the category 2B, you can go for a preoperative chemoradiation for a selected group of patients. Again, it has to be decided into the clinic, in a joint clinic. Or if the patients are medically unfit or medically fit but unresectable, you go for a chemoradiation. In a non-surgical, you can go for a palliative treatment. So surgery definitely is the main treatment. But nowadays we have a role of perioperative chemotherapy, which is a category 1 for gastric malignancies. And if the patient has not received perioperative chemotherapy, say suppose the patient was of a clinical T2 or a T1, and we directly went for a surgery, and if it was a R0 resection, you observe if it's a T1. If it's a T2, you can observe, or you can go for a chemo radiation. I mean, the chemo followed by chemo radiation followed by adjuvant chemo for a selected group of patient. But if it is a T3 beyond tumor and node positive, if it's a D2 resection, which nowadays all the surgeons do, you don't do anything. You only add chemotherapy, no radiotherapy required. But if it is less than D2, if it's a D0 or a D1 resection, you go for a 5-FU based chemotherapy, followed by chemoradiotherapy, followed by further chemotherapy. So the role of radiotherapy is very limited nowadays. For R1, R2, definitely you go for a chemoradiation for those patients. And if you are given preoperative chemotherapy and this patient has a R0 resection, you observe or you give adjuvant chemo. So again, no role of radiotherapy, even if there are nodes positive for a patient who have received preoperative chemotherapy. But yes, for R1 or R2 resection, you have to give adjuvant chemoradiotherapy with a 5-FU based chemotherapy. So which are the possible candidates for adjuvant radiotherapy? You do it, if there is an inadequate lymph node resection, if it's a D1 or a D0 resection, interstellar type of gastric cancers, a T3 or a T4 disease, a patient having positive nodes or a high nodal ratio. These are the indications for adjuvant radiotherapy. But absolutely radiotherapy indications are a patient who has gone for a less than D2 resection, or a patient who has a more than R0 resection, maybe a R1 or a R2 resection. These are the absolute indication for adjuvant radiotherapy. Otherwise, our role has been limited in stomach malignancies. So I'll conclude my talk here, and I'm ready to take any questions if there are any questions.
Thank you, Dr. Kinjal. A very nice presentation and a very crisp presentation, I must say. I think the role of radiation in gastric malignancies has shrunk a bit. But then do you think that coming in of Top Gear and Critics 2 trial, which is still ongoing, as you very correctly mentioned in your presentation, can that change the game as far as the radiation is concerned?
So as far as the adjuvant is concerned, I think it is not going to change. The role might come in the role of, I mean, the neoadjuvant setting. We have had a few patients, I'm just extrapolating my data, like we treated a few patients around 7-8 years back having advanced esophageal malignancies, and we have given for a neoadjuvant chemotherapy followed by cross regimen. So we gave neoadjuvant chemo followed by chemoradiation, followed by surgery, and those patients did comparatively better than going for a neoadjuvant chemo followed by surgery. So maybe this Top Gear study or a Critics 2 might give us an idea about the role of neoadjuvant. But yeah, in the adjuvant setting, I think the role is going to go further down. Right. And because nowadays we see a lot of D2 dissection. We have good surgeons, so we do see a lot of good D2 dissections. So
certainly.
It is going to reduce for sure.
And when you talk about the chemo followed by chemo RT, are we talking about CVET 3 and gastric, or are we talking about CVET 2 more?
No,
because chemo plus followed by chemo RT in most of the phase 2 studies also has been done more in CVET 2 compared to CVET 3 and gastric.
Yes, also CVET 3 and gastric are like flawed. You are mainly into perioperative chemotherapy. So CVET 2 is an area, it's a gray zone, where you can go for a cross trial also, you can go for a chemo and then followed by chemoradiation. So yeah, I would say CVET 2. 3 maybe, maybe 3, but we are more into flawed for a CVET 3.
Yes, right. Thank you so much. Thank you.
Thank you.
So we move ahead and to kind of deliberate more upon CVET 1 and CVET 2. We have with us Dr. Vikas Talreja. Dr. Vikas Talreja, of course, needs no introduction. He is a consultant medical oncologist at Regency Hospital, Kanpur. Dr. Vikas, hi. Good evening. Dr. Vikas is going to talk about the neoadjuvant approach in locally advanced GE junction cancers, from controversy to consensus, how it has moved in the last few years. Dr. Vikas.
Thank you. Thank you, Dr. Rajat. I hope I am audible right now, and my slides will be shared by the backend team. A very important and a very brilliant agenda, I must say, because it has been my privilege to look at this agenda. It's a very relevant agenda so far now.
So can we have the slides, please?
If it is difficult, then I will share from my end. So thank you, Dr. Rajat, again for giving the opportunity. And while we start, a very good background has been set up for the upper GI right now. We'll
So, Vikas, can we request you to share the slides if you are
give
okay
me
with
give me
this?
give me a minute. Give me a minute. I will do that. Okay. I hope my slides are visible right now.
Yes, sir.
I will make it
Yes.
full screen. Perfect. So as beautifully the background has been given for again the TNM 8th edition, the type 1, type 2, type 3 CVITs which we have is based on the cardiac location of the stomach, and a lot has changed into the molecular classification of the stomach cancer, as we see from the genomic atlas to the ACRCG subtypes. We have right now different.
So sorry to bother, but you need to run the slides. It's still at the slide 1.
Okay, so I will share it again. It happens. Is it fine?
It's hanged up now. Can you just scroll to the slide number 2, sir?
So if you can permit, I can share this.
Yeah, Aram, aap share. Okay. Yeah.
Perfect. So next slide, please. Yeah, so we have seen a lot of molecular classification being done for the stomach cancer um, um, from EBV type, where we have the PIK3CA mutation, this cycling dekinase 2A silencing, the JAK2 amplifications, and the PDL1, PDL2 amplifications, to the microsatellite instability, which is forms the major 22% of the group, where we have the hypermutilation of the targetable oncoproteins, the genomic stable type, where we have the CDH1 mutations, which is the mostly in the diffuse type of cancer, and in CIN, that is chromosomal instability type, where the RTK amplifications, the TP53 mutations, and the aneuploidy occurs. So the classification has been with us throughout. And what has the treatment significance? Next slide, please. So when we look at the standards across the peri-op chemos and the radiations, we look at the NCCN, the ESMO, the Japanese, and the Chinese society. Next slide, please. And all across, we feel that the peri-operative chemotherapy has been here to stay. So be it an operable also, even it's a T1, more than T1 lesions, the pre-operative chemotherapy in adenocarcinoma is there. Instead of going directly for the surgery, the preferred pathway is always the pre-operative systemic treatment. Next slide, please. In those with junctional CVAT 1 or 2 type, also the neoadjuvant chemotherapies, the perioperative chemotherapies is the preferred pathway, directly proceeding towards the surgery, because we know that it has a prognosis. Next. So the principle of neoadjuvant or the peri-op is that it increases the R0 resections, reduces the recurrence, reduces the metastasis, improves the survival, and it gives us in vivo sensitivity as how the patients are behaving with the indwelling chemotherapies inside. and also the compliance of the patient to the long-term treatment for it. The cons has been delaying the surgery, but again, that has been the only reason why the definitive treatment is there. But the perioperative chemotherapy serves as a stimulus test for most of the patients. The current standard is the FLOT, and we all are using it day in, day out for most of our patients, coming on from this Lancet study, which was published for the gastric and gastroesophageal cancers. For those who are technically operable, more than T1 lesions, any node positive, a very simple regimen that we use is docetaxel 50 milligram per meter square, 5-FU 2600 milligram per meter square, and oxaliplatin 85 milligram per meter square every 2 weekly. The current standards which were there to which it was compared was the ECF or the ECX regimen, and the stratification factors were on the base of the performance status, the location of the primary, age, and nodal status. Next slide, please. And all across, it was uniformly stratified population. So both of them were uniform characteristics across the age, sex, and the location type, and the nodal status, and the Lauren classification. Next slide, please. So you could see that the FLOT clearly outcast the current standard for it, which was the ECF or the ECX, with the median overall survival with 50 months with the FLOT survival, as compared to the ECX, where it was around 37 months with 23% reduced risk of deaths as compared when you give FLOT as compared to the ECF regimen. With a 5-year overall survival rate of 45%, it became a standard of treatment across. Next slide, please. And which subgroups it benefited, you could see that across all subgroups, it's had a uniform and relative effect, that the FLOT had a good hazard ratios across all the subgroups, be it a sex, be it age, be it any stratification factors, nodal, or the TNM staging. Everywhere the FLOT was uniform to stay with. Next slide, please. So the median DFS was also quite high. You could see that 25% reduced risk of events with a 5-year DFS of around 41% with FLOT. Next slide, please. It became the new standard for it. So FLOT increases the tumor surgeries, it increases the R0 resections, it included more negative nodal status, and it became the standard of treatment. Next slide, please. And for those who feel that FLOT can't be given in a remote setting or in a rural situations, 5% of the patients receive GCSF with a primary prophylaxis, and secondary prophylaxis 34% of them. With a tolerable neutropenia side effects, I believe the treatment was there to stay. So 60% patients got FLOT in post-op, with 46% at the end of the day. Compliance means that half of your patients tend to complete those 8 chemo regimens which are planned for them. Next slide, please. So FLOT was the current standard. If not suitable, doublet was the treatment. So peri-op chemotherapy was there to stay. Next slide, please. Now, the other regimen, which was, I believe, primitive regimen, was a cross regimen for the Sieverts 1 and 2. Next slide, please. And in adjuvant also, when we do the standard treatment, because many of these patients in Asia was considered for an upfront resections before the perioperative chemotherapy became a standard. The role of immunotherapies was established by the Checkmate 577 trial. The Prodigy trial also showed the adjuvant chemotherapies. So only those patients who underwent radical gastrectomy without neoadjuvant therapy, more than 16 lymph nodes, were the situations where the adjuvant treatment was considered a standard. Next slide, please. Next. So for those where the neoadjuvant wasn't given, the Zelox and the SOX regimen, the Chinese studies showed a standard of care. Next slide, please. And there was a good data for S1 plus docetaxel, which also improves the relapse-free survival as a doublet chemotherapies if those who are FLOT ineligible patients, nearly 67.7% as compared to 54%. Next slide, please. No effect on the overall survival, even though you see that there is an improved PFS advantage with it, 66% versus 60% with the addition of the S1 as per the Prodigy trial. Next slide, please. The revolutionary treatment came from the addition of the immunotherapies. The nivolumab was given in 577 trial, where the cross regimen was being followed because the trial was started when the cross trial was the standard of care. Next slide, please. And you could see, next slide, please. Next slide, please. All across there was uniform factors that the addition of the adjuvant nivolumab significantly improves the disease-free survival as compared to not giving any therapy. So a nivolumab given for more than a year benefited across all prescribed subgroups in the esophageal and the junctional carcinomas and became a standard of care across the globe. Next slide, please. And you could see that there was a hazard ratio all to the left that is favoring nivolumab with 40% reduced risk of disease-free of any event in case of esophagus. In gastroesophageal junction, it had a 0.87, meaning a 13% reduced risk of progressions, be it with whatever histology, adenocarcinoma or squamous cell carcinoma, even though it benefited adenocarcinoma more than the squamous cell carcinoma, but again, the benefit was there. 40% with the squamous cell carcinoma benefit and 25% with the adenocarcinoma reduced risk of events. Next slide, please. The PD-L1 expression as is a biomarker was also consistent with this. Next slide, please. The tolerance also, you could see there was, even though the side effects were reality comparable, discontinuation due to adverse events with nivolumab is 9% as compared to 3% with the placebo. Next slide, please. So in gastric adenocarcinomas, adjuvant chemotherapy has become a standard key treatment in Asia. In Europe, adjuvant is used when surgery has been performed first, emergency or stage underestimation, post-operative chemoradiation may be discussed in few cases. Next slide, please. Junctional, we use cross regimen and then adjuvant nivolumab in case of residual pathological disease, YPT1 or N1. Next slide, please, with EMA approval. Next slide, please. Next. So when we deal with the esophageal and the gastric cancers, we also have to deal with a lot of supportive care because malnutrition is a severe epidemiological problem which increases the morbidity in these gastric patients. Proper detection and management of nutritional disorders is mandatory. Nutritional therapy demonstrates a quality of life, adherence, tolerance, tumor response, and survival. The prevalence of the muscle loss and sarcopenia in gastric cancer is high. Sarcopenia is often associated with malnutrition, is often poor prognostic factors. Exercise training intervention is feasible and safe and can be done early, before and after the neoadjuvant treatment. Next slide. And that's where also very important, which has a very important biomarkers. Next, three next. You could see that the circulating tumor DNA has a prognostic factor. When it is detected preoperatively, it's a predictive biomarker for the pathological response. When it is detected at the surgery or after the surgery, it's also associated with significant shorter DFS and overall survival. And circulating DNA is a marker of a minimum residual disease before CT scan. So usually it appears before CT scans by a period of around 6 to 10 months, and therefore ctDNA can be used to guide our adjuvant treatment for most of our patients. Next slide, please. So neoadjuvant, also we feel that the MSI has a very important role because most of the chemos fail in the MSI and most of the immunos score in MSI. So MSI status is a prognostic role for those patients with the surgically resected gastric cancers, and there is a potential lack of benefit of perioperative chemotherapies with the MSI high status. Next slide, please. And if you could look across all these trials, the MSI is where the responses rates are high with the immunos as compared to the chemos. And that's where immuno checkpoint inhibitors are highly efficient in the MSI high metastatic gastric tumors. Next slide, please. And we have been discussing radiation a lot, but we have to also know that radiation does have a role also in healthy tissues also. So we have to balance that therapeutic ratio. Next slide. Next slide. So there is a very narrow difference between a therapeutic and a toxic effect, and that's why it is important that we maintain that it Even though the goal of the radiotherapy in G junction and gastric tumors is to downstage the disease, increase the R0 resections, decrease the local regional recurrence, and improve the survival. Next slide. The distance is something which is, next slide please, where the cross trial you could see, and also the POET trial where the two combination of the chemos and radiations was tried in stomach cancers. And you could, next slide, you could see that there wasn't much beneficial of addition of the radiation to the systemic treatment, which clearly outlived for it. Next slide please. And you could see in some cases it was detrimental to add radiation as compared to the chemos. Next slide, please. The New Ages trial.
So sorry to interrupt. Last 3 minutes to conclude, sir.
So you can go to the last slide of mine. Next slide. Yes. So perioperative chemotherapy was not unacceptably inferior to the cross regimen. With a 3-year survival rate, the markers of response includes the pathological complete response, major pathological response, nodal downstaging, significantly better in the cross arm. There was no statistical difference in the severity of complications or specific index complications or post-operative mortality, hence no negative effect, but yes, the positive effect has been next. An artist 2 trial is which is going to explore in the node positive. Next slide. And next slide. You could see there wasn't much beneficial addition of it. To conclude, a multidisciplinary approach is essential in the treatment of this disease, as what type of treatment, which drugs, what volume to irradiate, radiation techniques, and what type of operations. Next slide. Next. So perioperative chemotherapy is the current standard in the gastric cancers preferred to the adjuvant chemotherapies in Europe. For junctional, 2 options are available: perioperative chemo, that is FLOT or chemoradiotherapy followed by surgery, and adjuvant nivolumab. Those with MSI high tumors must be identified early because they might not benefit from the new adjuvant and adjuvant chemotherapies. The prognostic remains in the localized gastric and junctional adenocarcinoma groups. Implementing supportive care with new adjuvant and adjuvant treatment is essential. That would be the end of my talk. Would love to have any answer if there are any questions. Over to the organizers for a beautifully organized conference so far now.
Thank you, Dr. Vikas. I have one question for you. We talked about the FLOT4 regimen where they said that only 5% patients in the first cycle, they were given growth factors. If you talk about the practical scenario, we have most of our patients who are not having a good performance status because of the disease. And also most of them, they are elderly. So what do you think? Do you give FLOT without growth factors in the first cycle, or do you use growth factors always?
So 1/3 of the Western population did receive secondary GCSF prophylaxis. We cannot take a chance for it. It's just a simple growth factor. I believe we should be prophylactically administrating. It is better to be safe than sorry. And that's why I believe, even though we can be confident that we can give FLOT to our patients, but the primary, without primary GCSF prophylaxis, I would say that I would be a little apprehensive. In my current practice also, I usually prescribe the prophylactic GCSF factors for all my patients.
Right. And what is the percentage of PCR being achieved by FLOT in your practice? 1/3 is what the trial said. What do you think?
I believe the real data also extrapolates with the trial data. Around 1/3 of my patients also have a complete nodal and the primary response. And I believe it is real world data for us also.
Right, right. Thank you so much, Dr. Vikas. Thank you for a very nice presentation, and stay back for the rest of the meeting. Thank you. So now we move ahead, and the next session is on metastatic gastric cancer and the G junction cancers, the first line treatment of it. And we're talking about how to really incorporate immune checkpoint inhibitors in the first line management of gastric and G junction cancers. And to talk about this, we have with us the prominent medical oncologist of the country, Dr. Shyam Agarwal, sir. Sir, good evening.
Hi.
Sir is the director and chairman of Department of Oncology at Sir Gangaram Hospital in Delhi. Over to you, sir.
So thanks, Rajat, for the opportunity and for the invitation. So this is a sponsored session, although towards the end I have included some of my slides. So this is basically, as Dr. Rajat said, focusing on immune checkpoint inhibitors in advanced or metastatic gastric cancer. So next slide, please. So, this is data is very rapidly evolving, and the drugs are available. So we should be aware of these developments so as to incorporate the immune checkpoint inhibitors in our day-to-day practice. So this is, if you look at the GE cancer, one can divide into esophagus, GE junction, and gastric. And I think more important here is to see and that nearly 50% of esophageal cancers are PD-L1 expressors. And if you look at gastric, from 25% to 65% of patients are PD-L1 expressors. So this is important because the checkpoint inhibitors currently show efficacy in patients who are PD-L1 expressors. So I think the figures are quite high, which is very important to understand. So this is the estimated number of patients whom we see each year, nearly 60,000 for gastric and 63,000 for esophagus. And majority of these are dying because of relapse, progressive disease, and our inability to cure them. And therefore, this is a huge, huge unmet need. Next slide. So, and that is the reason for failure, because less than 20% patients are localized and majority are loco-regional or with distant metastasis. Next slide. So 5-year survival is just 10%. So what are the current biomarkers? As we just shared with you, PD-L1 expression is seen in 50% or even more. And there are contradictory reports whether PD-L1 expression is associated with inferior survival or better survival because of infiltration by lymphocytes. I think we all know HER2-neu, and the MSI high is a tumor agnostic marker, but the problem is the detectability of this is just in less than 10%, and you are usually thrilled to see somebody who has MSI high because of the exquisite response rates with the immune checkpoint inhibitors. So I think these are 3 tests. So it goes on to say that if you have a patient with metastatic gastric cancer or a GE junction cancer, so I think upfront we should be asking for these 3 reports because they help us in taking decisions regarding the management and which drugs are to be used. Next slide. So this is Opdita, which we all know, nivolumab, which is a PD-1 inhibitor. I think we all understand that the T cells which are inhibited with the help of nivolumab, so that inhibition is gone and they're able to kill the tumor cells. Next slide. Next slide, please. So this is the CheckMate 649 study. Where, as you can see, nearly 1,581 patients were included, and they all had adenocarcinoma, and HER2-neu was supposed to be negative. And the PD-L1 expression was done, which was a stratification factor, and there was a Chinese subgroup with 208 patients. And you can see that 60% of these patients had PD-L1 CPS more than 5 in the overall group, and 75% had the PD-L1 CPS more than 5 in the Chinese group. So suffice it to say that majority of the patients, if you look for CPS in adenocarcinoma of the upper GI malignancies, they'll be positive for CPS more than 5. And as you see here, there were 2 arms, K-pox or Folfox with or without Opdita, 3-weekly 360 or 2-weekly 240. And the primary endpoint was OS and PFS. And there were other endpoints regard to CPS scoring. And then, of course, the quality of life. Next slide. So I think the PFS and the OS were initially looked upon at CPS more than 5, and depending upon the alpha, the analysis was, subsequently conducted onto PDL1, CPS more than one, and then if that was also significant, then all were sort of randomized. So that was the statistical design. Next slide. So those are the baseline characteristics. A big trial, as I told you, that patients, nearly 800 plus in both the arms, with or without Opdita. And you can see here that the gastric cancer was 70%, GE junction was 18, and esophageal was 12, but all had to be adenocarcinoma. And I mentioned about the PDL1 expression, which was, 23% here in approximately 20%, but the CPS scoring, as I told you, was high in both the subgroups. Next slide. And I'll show you the next slide. Next. So, no, can you show the previous slide, please? Yeah, so, majority of these were metastatic disease. And and if you look at the K-pox and FOLFOX, that was equally divided. And the MSI high, as I told you before, was just 3 to 4%, a very small number. And if you look at the classification, intestinal or diffuse type or unknown, so that was sort of equally distributed. Next slide. And nearly 40% had liver metastasis. So this is the sort of the primary endpoint, which was overall survival, which is important to say that patients who got Opdita and the CPS was more than or equal to 5, the 2-year overall survival was 31%, or as compared to 19% without Opdita, so with chemotherapy alone. And the hazard ratio was 0.70, which means there was a 30% reduction. So median overall survival was 14.4 versus 11.1. But if you look at all randomized patients, patients who had CPS less than 5 or even nil for that matter, the hazard ratio was 0.79. So, and the 2-year survival rate, as you see here, is 28 versus 19%. So that is the data as it is seen here, and 28% of patients alive at 2 years. So which is, I think, a reasonable gain as compared to patients who are not getting Opdita, especially in the subgroup of patients who are having a CPS equal to or greater to 5. Next slide. And this is minimum follow-up of 24 months. So looking at the progression-free survival, one sees here the hazard ratio of 0.78 versus 6 months, and 7.7 versus 6.9 for all randomized. So again, you see the difference is there, like you saw with the overall survival. Next slide. So the focus is on CPS more than or equal to 5. So this is to show you the response and demonstrated overall response rate, which was higher, including more than 10% complete responders. You can see 47% partial response and 13% complete response, and the overall response 60 versus 45% in the CPS greater than 5. Here it was 58 versus 46. Next slide. So this was expected, although minority had MSI high, and you can see the hazard ratio, very much in favor, 0.38 for MSI high group when you use Opdita with chemo. And for MSS, you can see, if you look at all patients included, all randomized, the overall response rate is 59 versus 4. So it is maintained even in MSS. So that is MSI high, as we know, we expect these checkpoint inhibitors to deliver. Next slide. So you can see consistent overall survival benefit across several pre-specified groups, whether it is Asia, as I told you, it was Chinese mainly, or male, female, raise. If you look at the gastric cancer, esophageal adenocarcinoma, and GE junction cancer, so the diamond is towards Opdita, and even the ECOG PS. Next slide. So I think there is again a chemotherapy regimen, whether it was K-pox or FOLFOX, didn't make a difference. PD-L1 expression didn't make a difference. Liver metastasis again didn't make a difference. So all subgroups tended to benefit. Intestinal, diffuse, or unknown also had the benefit. Next slide. So I think so for patients with CPS less than 1 and less than 5, you can see the overall survival, the hazard ratio, sort of going up, indicating that the main beneficiaries of the treatment were patients who had CPS more than 5. Next slide. This is longer duration of response across the CPS cutoffs. As you can see, the median duration of response 9.5 versus 6.9 for patients with CPS more than 5, and a lesser benefit as you go down the CPS. Next slide. So I think these are busy slides indicating again that the maximum benefit in terms of response rate, duration of response was better for patients who had CPS equal to or greater than 5. Next slide. So I think more patients progressed when the patients were on the chemotherapy alone arm as compared to Opdita. So next slide. So I think these are the subsequent treatment which patients received, which were, so actually there's a huge dropout here because 63% or so, almost 60% patients, did not receive any treatment. So beyond chemo or the chemo plus Opdita, and there was a fair distribution, as you can see, between taxanes and other drugs, including ramucirumab, and even radiation. Next slide. So those are busy slides. I think we don't have time to go through all this in detail. Now coming to the side effects, suffice it to say that there were no major new signals. You can see here, no new safety signals. So I think we'll not spend much time with this. Next slide. So I think these are all side effects, as you see, the ones with Opdita, in less than 5%, as you see in your day-to-day practice. Next slide. Okay, they did not result in additional bother from treatment side effects. So this is coming to the quality of life. This is the FACT gastric GP5 scale. And so I think there are several slides to this effect. I'll tell you next slide. So that it didn't really bother, the addition of Opdita. So you see change from the various scores is not much. So the quality of life was really not hampered by the addition of Opdita. Next. So this is again a similar slide demonstrating that did not result in deterioration of quality of life. Next slide. So I think we can skip a few of these. There's actually delay in the deterioration. Next slide. So I think you've covered. So I think on the basis of this result from 649, the approval for India is there for adenocarcinoma, metastatic disease in combination with either K-pox or FOLFOX. And I told you the dose. So chemotherapy is given for 6 months, and nivolumab is continued for up to 2 years. Next slide. So I think I've covered this. The dose is different for 3 weekly versus 2 weekly, and the Opdita is given for 24 months. Next slide. So I think that's the summary slide. Although the indication approved for DCGI is for all comers, but I think the maximum benefit, as I showed you, is for patients who have a CPS greater than 5. Next slide. So this is a couple of slides that on the similar lines where we have data for pembrolizumab with chemotherapy in esophageal cancer. And so I'll just show one slide. Next, we'll show you so this is chemotherapy with or without pembrolizumab. So here, if you see the esophageal cancer, pembro plus chemo and pembro, chemo without pembro. So the maximum benefit is for patients with CPS more than 10, and you can see the hazard ratio being 0.64. And you also see some benefit here for CPS more than 10 for patients with squamous cell carcinoma of the esophagus. So that is another drug which one needs to sort of keep in mind for combining with chemotherapy. Next slide. So that's the first line. And these are sort of a summary slide from where the drugs really began in terms of the efficacy for second or third line or even beyond that. And there is approval for using nivolumab and pembrolizumab for patients in third line, in particularly because if HER2/neu negative, you have ramucirumab and pacli in the second line, and then one can think of using these drugs in the subsequent lines. So I think the last couple of slides, next. They show you the NCCN guidelines. So for patients who do not have there's no negative overexpression of HER2/neu. So fluoropyrimidine with oxali and nivolumab, especially for PD-L1 CPS more or equal to 5, is the first line indication here. And even for esophagus adenocarcinoma, as I showed you, so whether it is gastric or esophageal or GE junction adenocarcinoma, so nivolumab is approved for the first line treatment. There's data for pembro for esophagus for adenocarcinoma as well. Next slide. And in the subsequent lines, I showed you that one can use drugs like pembro or even nivolumab in the third line after the failure of Capox or pacli and ramucirumab. And I think one can also, I think that thing is not visible if the tumor mutation burden is greater than 10, then one can think of using a drug like pembrolizumab. So I think we really need to keep ourselves updated with these newer developments in patients with metastatic gastric cancer or adenocarcinoma or even esophageal cancer for that matter. And we need to really do the CPS score, HER2/neu and MSI testing for all our patients before we take a call on what combination is the best for your patient. So with this, thank you very much.
Thank you very much, sir. A very nice and lucid presentation and pearls of wisdom coming from you. Sir, a couple of questions. Sir, do you think that we should restrict our use of nivolumab in this setting only for patients who have got a high PD-L1 expression more than 5 in CPS score, or is it possible for us to use it in either a nil expression or less than 5 as well?
So as I showed you, the maximum benefit or is for patients who are CPS greater than 5. So I think we're not looking at PD-L1 staining by TPS, etc. So I think we must insist on CPS scoring, because as you saw the difference, because only 23% patients were PD-L1 positive, but nearly 60 to 70% patients were CPS. So I think that that thought process should also be pretty clear. So now, if the CPS is more than 5, then there is no discussion in our mind. But now, if the CPS is between 1 and 5, so I think there is a room for discussion, because the approval is there from the DCGI for using the combination of nivolumab and chemotherapy. So I think we can explain and document the benefit to the patient, and maybe that's an open question, because as I showed you, NCCN is saying CPS score more than 5.
Yes, so the reason why I really pointed that out is that there is a dichotomy. NCCN says that it has to be PDL1 more than equal to 5, whereas their DCGI approval has come for all comers. So that was the thing. I think the quantum of benefit is the most if there is a high PDL1 expression,
Right.
as is there in many other indications. And sir, the last question is that in your experience, what has been the use like, and are there any adverse events that you've noticed with the combination of Folfox and nivolumab?
So I think the approval came quite recently. So we haven't really used the combination so far. We've started doing the CPS scoring for all our patients with gastric cancer and a GE junction adenocarcinoma. So I haven't really, and unfortunately, the patient assistance program is not available. So it's really an expensive proposition without the PAP. Because
Yes,
I think you can understand the 360 milligrams.
Yes.
So I think, as I said, this is evolving so very rapidly, and therefore we must start discussing now that we're getting patients for kidney cancer and even for lung cancer who are, now affording 3 lakhs and 4 lakhs and so on. So why not for GE junction and gastric adenocarcinoma? So I think we must start looking at that very seriously.
Right, sir. Thank you so much. And I would like to tell my audience that we are lucky enough to have sir with us for another session later in the evening on colorectal cancer. So thank you so much, sir. We'll see you after some time. Thank you. And so now we move ahead and over to the...
Dr. Rajat, just a small request. Dr. Lokwani is not able to join because of the poor connectivity. So we are just requesting Dr. Kshitij to join in a minute, sir. If we can have a couple of questions, just 2-3 minutes.
Yeah, right. No issues.
Aram, can you just send the link to Dr. Kshitij, please? He's just waiting for the link. So Rajat sir, you can have some question. Dr. Sham sir is there. Dr. Vinita Goyal ma'am has joined. Good evening. Dr. Kripa Shankar sir is there. Yeah,
right. Rajat, so I think the interesting part in gastric cancer, as we are beginning to understand, so the heterogeneity of gastric cancer is becoming quite important. I think I had one last slide in which even patients who have EB virus, mediated gastric cancer, they're also supposedly, beneficiaries of immune checkpoint inhibitors. So I think with the improvement of these understanding of various subgroups, although in this, the diffuse type, the intestinal type, etc., so they had virtually a similar benefit. But I think if you start going to the molecular level, there is a lot more to be understood, so that one can predict. Even though we are saying this hazard ratio 0.7, so I'm sure there is a lot of patients who are not doing that great. So we need to actually exclude those patients from exposing them to these expensive molecules because they are not benefiting. But we really don't have that data at this point in time. So a hazard ratio of 0.7 is not a huge benefit. But that, since that is statistically significant, and we are going to use that in large number of patients who even may not derive benefit from this.
Yes, sir, certainly. And sir, also, like you very rightly said, that one has to really weigh in practicality the cost and the benefit ratio. So there is a huge cost involved, and then of course, once if you have a PAP, then it becomes a little better. But then for a patient to have a metastatic gastric cancer, where we are not looking at a survival in excess of 2 years in any case, and telling that patient to bear that much of cost, with our country being a cost-sensitive market, that also remains to be seen. So maybe in times to come, we'll be better off in really selecting our patients wisely, maybe on the basis of molecular data more, if it comes in, like you very rightly pointed out, to offer these patients these drugs to those patients where actually the benefit is the most in the clinical trials as well.
Right. So I think as I showed you, and in 649, 28% patients were alive at 2 years. So,
Yes.
which is a significant gain. And as we all know, patients who get a PR or a CR, so I'm sure, like lung cancer, kidney cancer, etc., a proportion of them are possibly going to get cured. So I think
Yes.
with more data evolving in that direction, so I think we'll have 5-year survival coming in maybe 1 or 2 years down the line. So, but I think that is the beauty of these immune oncology drugs. And then, of course, I wish there is some kind of immune score, which I think I'll show you in colon cancer. So, you know, I mean, there should be a scoring system to identify who are the patients who are likely to benefit from these immune checkpoint inhibitors. So I think more work is required in that direction. I'm sure people all across the globe are focusing on that because of these costly drugs. So I think we really need to work on this.
Right, sir. Point very well taken. Yeah. Mr. Mathur, can we?
Sir, Sunit sir had joined. Can I invite?
Okay, right. So I again thank Dr. Shyam Agarwal sir for a very nice elucidation of the topic. So now we move ahead, and we have with us Dr. Sunil Lokwani, who is a consultant hematologist and medical oncologist from Shalby Hospital, Jabalpur, and he's going to talk us through the abstract from the recently concluded ASCO GI, especially focusing on hepatocellular carcinoma. Over to you, Dr. Sunil.
So, Dr. Sunit, you need to unmute yourself. Dr. Sunit, can you hear us, please? Yeah, Dr. Sunit, we can't hear you.
Sir, Kshitij sir has also joined. Can we have his talk first, then we can have Sunit sir talk?
Yeah, Dr. Rajat sir, are you there? Can we invite
Yes,
Dr. Yeah, Dr. Kshitij is there. Yeah.
Sure. So I think there is some issue with the connection in Dr. Sunit's laptop. So maybe we will have him after Dr. Kshitij's talk. So yeah, I think we have Dr. Sunit. Dr. Sunit, can you hear us? Is
I
it?
can clearly hear you. I don't know whether my network is working on because I had an issue with my Wi-Fi. I'm right now on the mobile part, so I'm really sorry for that network glitch.
No issues. We can hear you, and your voice is also audible and video is clear, so we can start.
Fine, please. I mean, I'll just I have it on my pad, and I'll definitely join. No issues.
Dr. Sunit, if you wish, we can run the slides from our side. You can just say next. Aram, we have the slides for Dr. Sunit, correct?
Yes, not an issue.
Yeah. So we
Not
have
an
the
issue.
we will play
Not
the
an issue.
slides from our side. So you just say slide next.
Please. Yeah. So thank you to the organizers for giving me an opportunity to speak amongst all the dignitaries present here. And the topic of interest here is hepatocellular carcinoma. The idea behind me being allotted the abstract presentation is that we might have something very fantastic and fascinating to come up with in the hepatocellular carcinoma front, where at one point of time we just had some procedures and one TKI to deal with. Subsequently, we had further TKIs to deal with, and now immunotherapy is coming up big time. So the abstract presentations which have been chosen here primarily focus on the combination therapy and the upcoming immunotherapy, which can be used to enhance our productivity when it comes to treatment, and increase the OS in patients of unresectable hepatocellular carcinoma per se. So the practice-changing abstract, which we'll be discussing in the next 15-20 minutes, will be focused on three. The first will be the Himalaya one, which combines tremelimumab plus durvalumab in a first-line treatment. This, they called it as T300 plus D, in short, to remember it. It was a very extensive study. It comes from MSKCC, the abstract per se. The next is, as we know, the keynote trials, which compared pembrolizumab in a second-line treatment in unresectable HCC. Now, pembrolizumab, nivolumab, both PD-1, PD-L1 things, they are taking up the landscape of management of cancers to a different level altogether. They are taking the world by the storm now. Practically, most of our cancers, we have some or the other point where we can definitely use pembrolizumab or nivolumab and definitely give a boost to the OS of the patient. The third is the launch trial, which focuses on combination of TKI with a TACE rather than TACE alone. So in the first line treatment. So we'll be just discussing the basic points and salient points of these three trials. And let's go ahead, please. Next, please. So as I told earlier, this is an MSKCC trial by Ghassan Saab. So it was a phase 3 trial, open label multi-center study with tremelimumab and durvalumab as first line therapy in patients with unresectable hepatocellular carcinoma. Next, please. So the study population is to be seen here. This was a very filtered study population, which you can focus here. Patients had unresectable hepatocellular carcinoma, PCLC-B, not eligible for locoregional therapy, and the C portion as well. The ECOG here was good. The child book A was the clinical nature of the disease, and the patient was in a child book class A. No portal vein thrombosis was seen, and EGD was not required. Endoscopic twist was not required in that case. So this was a good number of patients which were studied. The power of the study was very high. That's 1,324 patients they studied. What they did, they segregated into 4 segments. They studied on 4 part of it. So the first was combination of T300 plus D. The second was durvalumab alone as monotherapy given 1500 mg once a month and was continued. And in the 300 plus D, they gave 300 mg dose first. That's the only one shot dose. And subsequently, durvalumab was continued. The third was the standard with the continued 400 mg BID of sorafenib, the standard dose, the full dose. The fifth was, what they did is they broke the dose of tremelimumab into 4 equal parts once a month. And subsequently, durvalumab was continued as earlier. So the idea here was primary objective being the OS, overall survival, with the combination of tremelimumab and durvalumab 300 plus D versus isolated sorafenib as TKI. Secondary objective, overall survival for durvalumab versus sorafenib. So that was the second part which they studied. So this is what we need to study, and they definitely had subgroups to assess. Again, they had additional secondary objectives of PFS, overall response rate, and other things which were assessed by the investigator according to the RECIST criteria. And safety definitely was studied in each of the trials. What were the side effects? What were the adverse effects? We'll have a slide for that, and we'll study that as well. Proceed. Next, please. So this was the baseline characteristics. What I need to focus here is basically the region they studied. They separated in Asia versus the rest of the world. So this was a good separation they did, of which they did a good percentage, and subgroup analysis was much better. And most of the patients who were in the unresectable hepatocellular carcinoma group. Here, what they've done is they had HBV, HCV equal population, and the ones with non-viral unresectable HCC was an equal population. And what you can appreciate is most of them, 99 to 98% of the characters, baseline characters, matched a child class A classification. So this is one thing to be noted. Rest subgroups also had the PD-L1 positivity, the AFP more than 400. That can be studied on a subgroup analysis, not on a larger scale that way. Next, please. So this was after the failure. They had second line studies as well. Next, please. It's not important that much. I want to go to that. Now, the primary objective, the overall survival for the T300 plus D combination versus sorafenib. So what we need to see here is the patient studies were 262 in this and 293 in that. Median overall survival with the combination was 16.4 months compared to 13.8 months. Though this 2.5 month median actually on a significant scale does lead to a good hazard ratio, does lead to good things, but definitely it's a step and a notch above the standard sorafenib treatment. That is what they need to mention and target it out. Probably in the time to come, they might refine it. The dosing might be refined. We might have a better OS. So it's just a starting step to the better OS part. That's what we need to focus here on. Next, please. Again, the same thing, please. Next. It was just a longer duration follow-up. The idea here was the OS was 30.7 months in a 3-year follow-up. That's what they suggested in the last slide. So if you see the forest plot here, comparing both the things, the only two areas wherein sorafenib has slight advantage is when it's given in the female population versus and the ones in which HC population was there. That favors more of a sorafenib being given. Rest all the baseline characteristics, be it patient male, be it a patient less than 65, more than 65, be it of an Asian or non-Asian origin, ECOG piece being 0 to 1, other criteria of AFP being more than 400, less than 400. The whole forest plot favors an activity of the oral, the response criteria favors basically to the combination of T300 plus durvalumab. Next, please. So this is one of the points wherein we decide whether to give that patient a drug or not. The progression-free survival is very good or not. We like to hit it on first line or not. So PFS is one of the deciding criteria for us as oncologists in many of the cases. And definitely PFS is important to us, but the study didn't target much, but it was more of a secondary criteria. What they mentioned here is median PFS was more of the, in both the combinations was more or less same and not different. But this definitely had a slight edge on the isolated sorafenib. Next, please. Again, this is one of the secondary targets wherein they compared monotherapy with durvalumab compared to sorafenib. This had a clear margin advantage, 16.6 months OS versus overall survivors versus 13.8 months with sorafenib. So a definite and clear advantage of 3 months is definitely far better than giving sorafenib alone. So durvalumab definitely as a monotherapy fares better. This can be one of the practice-changing points in years to come or in the future to come when we have further larger trials with it or larger rationalizations and analysis with it. Because 3 months is a significant advantage when it comes to a patient for whom you are giving a first-line therapy. So definitely durvalumab fares better when it comes to OS compared to sorafenib in an isolated therapy. Plus, it has the advantage of being given once a month. Sorafenib has to be taken daily. So that means one thing is there. Third thing, which an advantage comes to my mind, which is not mentioned here, if a patient is receiving durvalumab, definitely the follow-up is much closer compared to the one receiving oral sorafenib. So that's one point which came to my mind on a clinical note. So I thought I'll share with all the seniors and elders and colleagues of mine. One thing that was there. Now the secondary objective, OS for durvalumab versus sorafenib. I told again, on a longer follow-up, definitely the same thing was that durvalumab fared better. Please next. So this was a tumor response. Few of the patients in the combination definitely showed a CR as well. So the percentage was much less, but still CR was evident and overall response rate was a good one. Next, please. Yeah, so this is one point where we'd like to focus. So when in clinical practice, we want to target something, we want the side effects or the treatment related adverse effects with a minimal part. So compared to isolated sorafenib, the combination and the monotherapy definitely had lesser grade 3/4 side effects. That is what we need to know in clinical practice. So this will definitely shape a decision making when we have our patients who don't want much of side effects, whatever life remaining is there, we need a good life. So to those kind of patients, definitely we can give a choice while counseling and sitting them with. But still, definitely data much has to come. It will definitely be a practice changing aspect in this case. Next, please. So conclusions, just to remember 3-4 points. It was a large study, as I told earlier, 1,327 people participated in it. And it had included a global heterogeneous population, Asian / non-Asian, we mentioned earlier. The median OS was 16.4 months for the combination versus 13.8 months for sorafenib. And it appeared to provide a long-term survival benefit with a landmark 36-month OS of 30.7% of cases. Now, overall survival of durvalumab monotherapy was non-inferior to sorafenib, a favorable risk-benefit profile. The combination regimen and durvalumab monotherapy may represent new treatment options for patients with unresectable HCC. So that was the bottom line statement. Definitely, it will be a practice-changing aspect in years to come. Please. Next. So coming to the next, this study, the keynote trial. So most of the keynote trials, are focused on the pembrolizumab. This study comes from China. What they did is they did pembrolizumab plus BSC versus placebo plus PSC. So how well does spending money on pembrolizumab fare when it comes to advanced HCC per se? Next, please. So what they did here, they studied around 450 cases, and in which 150 were in the placebo group and 300 were in the pembrolizumab group. Herein, the eligibility criteria of patient should have a confirmed HCC. The disease should be measurable as per SS. Patient should be child class A, PCLC stage C or B, not available or refractory to local regional therapy, and not amenable to resection as well. So this was the thing. The primary endpoint here again was the overall survival. Secondary endpoint thing, PFS, ORR, DOR, other things. Next, please. So the baseline characteristics, what we need to focus major here on basically is people from other populations were also considered, but the numbers were very less. The alpha fetoprotein level was also taken as a baseline character to be studied for subgroups. Other thing, they had enrolled people who were elderly as well. And most of the patients here were hepatitis B positive. This is one thing which we need to see. Other thing which we need to see here is, this is a second line study. This is not a first line study. The patient's treatment was second line. So most of the patients had received a sorafenib-based treatment. Next, please. So the OS, when it comes, 14.6 months versus placebo 13 months. That's what I need to just convey in this one. At the end of 2 years, what they came to the OS part. And this was definitely a modest overall advantage compared to placebo, but definitely it is an advantage. Next, please. Yeah, the PFS part. So PFS was not much great, not that changed, but definitely it had an effect on the OS. Next, please. Yeah, I'm sorry. I forgot to mention that PFS advantage was definitely there in the 11% of population. So objective response when they assessed, they definitely observed some CR with patient receiving pembrolizumab compared to the ones who were on placebo. The definite, the numbers were not in a proper ratio. So definitely pembrolizumab fared better here, and a partial response is seen with most of the cases. And significant stable disease, significant population, or the number of studied population, that is around 40%, showed a stable disease. At least there was no progression first. So in combination, when you combine stable disease, progressive disease, partial response, complete response. So when you combine these three percentages, it fares definitely better. It's more than 50% of the time of the population study. Next, please. So overall survival based on meta-analysis of Keynote 394 and Keynote 240. What they recommend here is it's 14.2 months versus 12.5 months. Definitely a good advantage when it comes to OS. Next, please. So the adverse event summary here. So there was one death on pembrolizumab arm. Patient had immune-mediated hepatitis, was a lesser percentage, and grade 3 to 5 side effects were seen, and again a lesser percentage. So this was what he wanted to show here. When it comes to immune-mediated adverse effects in pembrolizumab part, and if it comes to treatment-related adverse effects, around 14% of the patients had treatment-related grade 3/5 side effects. And in 4% of the cases, they saw side effects which led to discontinuation. And 1% of the patients definitely were lost their life and couldn't continue. So the numbers here were fairly low. If you come to the summary and conclusions, use of post-study anti-cancer therapy at progression may have attenuated the observed treatment effect. Meta-analysis showed pembrolizumab therapy provided a consistent treatment effect when it comes to placebo versus pembrolizumab. Adverse effect profile was manageable, and it's always a risk-benefit ratio, and pembrolizumab fares better when it comes to this. Next, please. So this is the last one. This is something really which is somewhat practicing. This decision also always used to haunt us, whether we should add some TKI to the locoregional therapy treatment, whether it will benefit or not, the adjuvant part or not. There used to be STORM and SHARP trials which showed that there was no much adjuvant treatment benefits. So I used to read them way back in my DM days, but still. So there's a new trial which has come up. It has shown something like lenvatinib plus stays versus lenvatinib Volovis first line treatment. So this is definitely modified that part. So STORM and SHARP studied the sorafenib part. This is studying lenvatinib as a combination with stays. So definitely things evolve. And this is again a Chinese study, a small part study, but it definitely shows the idea behind this was reflected in the next slide. Next, please. Next, please. Yeah. See, this was a potential treatment strategy to enhance the efficacy of lenvatinib for advanced hepatocellular carcinomas when combined with TACE. So the idea here was TACE reduced tumor burden in a short time. Post-treatment neovascularization may lead to tumor mets and recurrence. When combined with lenvatinib, it inhibited angiogenesis, inhibited tumor cell proliferation. So the idea was TACE plus lenva is definitely more effective than lenva alone. Next, please. Again, the schematic diagram of enrollment and all. So just a brief. What they stratified was tumor thrombosis there or not, body weight less than 60, more than 60, ECOG performance status, and there should be one measurable lesion as per RECIST criteria, single lesion less than 10 centimeter, number of multiple lesions less than 10, tumor burden less than 50%. All these studies carried child class A, child 2 grading criteria A. Again, primary endpoint was OS. Number of patients studied in both the arms were equal. So this is the primary thing. Next, please.
Sir, you have 2 minutes to conclude your discussion, please.
I'm about to end, sir. I'm about to end, sir. So this is the baseline characteristics. Please proceed. Nothing much. Next, please. So when it comes to len plus TACE versus a len group, definitely, if you can see the table, you can definitely appreciate there was a significant benefit with partial response, stable disease, and complete response seen in a higher percentage of patients who had received a combination. So this is what is to be seen here, which is according to the RECIST criteria. Next, please. Yeah. Now, survival outcome, definitely OS was the last point. Median OS was 17.8 versus 11.5 months. The hazard ratio was 0.45. Without disease progression, the median PFS was 10.6 versus 6.4. Definitely faring better. So, what we do here when combined with lenvatinib plus TACE in local regional region. Next, please. Yeah, this is clear for you see. I don't think so I should mention anything on that. Next, please. Yeah, so all grade adverse events were seen there, but these were manageable primarily, and they didn't have any effect on the OS per se. Next, please. Conclusively, lenvatinib plus ACE was safe and effective for patients with advanced hepatocellular carcinoma, demonstrating remarkable improvements in the OS, PFS, and overall response rate, as well as acceptable toxicity. Lenvatinib plus TACE represents a potential new first-line treatment option for patients with advanced SSC. Definitely fares much better on this front. So there are a few glitches in it. The first thing was that regulatory approval from FDA plus DGCI with this combination, despite being a good result. Then there was earlier study which had contradictory issues and brave. And the availability of tremelimumab in India, durvalumab is definitely available. Then again, keynote pembrolizumab showed a good result with pembrolizumab, but definitely it's a second line study. So no immunotherapy in the first line, when to give. So that's why we don't have a baseline to compare to. And the idea of lenvatinib plus TACE, again, hepatitis B patients are in a jiffy what to do. So these are some of the few queries which need to be answered still when you have these practice saving abstracts. So probably in the time to come, we will have an answer to these as well. So this was my time. Thank you very much for listening, and open to questions or whatever.
Thank you, Dr. Lokwani. These three abstracts from ASCO GI, less talked about is hepatocellular carcinoma and its management. I think you'll agree in the CMEs, but then hepatocellular carcinoma is one of the very common cancers that we see in our practice. And we as medical oncologists feel very scared of sorafenib and its side effects. So probably, like you said, the first trial, which was durva plus tremelimumab, will give one of the options over sorafenib. Of course, the availability is an issue. You think that the IMBRAVE 150 combination, it will have a competition once this combination comes up? If you look at the hazard ratios and the
competition fares better results, Dr. Rajat. Competition fares better results. So whichever fares better will definitely come out on top. So I'm not worried about that. I'm not worried about that. The question here right now is basically, as you told it to start with, HCC is a less looked on or less researched upon entity per se. 10 years or 20 years back down the line, lung cancer was the same, but now we have an entity of driver mutations bringing up the landscape of lung cancer to a different whole level. So the same thing has started up with HCC. We are getting immunotherapy to a different extent in HCC per se altogether if you combine and talk to me on it. So immunotherapy is definitely going to be a landscape change in the management of HCC in the years to come. That's what I believe after reading all these trials and all. That is what my general consensus is, being the youngest of the lot, I believe. And I'm really sorry, I'm stopping you for another question, I think, sir. Anything you wanted to ask or something like that?
Of course. So what I was saying is that atezo plus bev combination also has got some contraindications. So thankfully, we have another combination which we can use in our patients.
Yeah, definitely, no doubt.
Right. Thank you so much.
Availability is
definitely is an issue till the time it is available. And another important issue is that Durva plus Tremeli combination in other cancers also, for that matter, be it lung or melanoma, it has not fared better compared to Durva monotherapy. So that also is something that needs to be seen. And same was seen in this Himalaya study as well. Yeah.
One thing I would like to mention, it is not done in any of the studies up in the West. One of the toxicities which we most commonly face in our clinical practice is the financial toxicity. So I don't know how long we'll be dealing with this financial toxicity wherein we are not able to give much of the treatment to our patients, and we definitely land up in giving half treatment, or we only give lenvatinib, only give TACE or something, because the patient is not affording that much. We don't have that insurance policy thing. So when I give this, Rajat Indori saab ka ek sher yaad aata, please don't mind me telling that, कि क्या था, that was हर किसी की मोहब्बत पूरी नहीं होती, कुछ किस्से अधूरे ही अच्छे हैं. So with that philosophy, definitely most of the times we give half a treatment or partial treatment to the patient because he's not able to afford. So that thing I think should curb down first rather than us talking about many improvement new molecules. So if we are able to give that thing, most of the things, what happens, आपकी जब दवाई आएगी, उसकी एक्साइज लगेगी, उस पे ड्यूटीज लगेंगी, उस पे रिसर्च मॉलिक्यूल का पैसा लगेगा, company will have invested in that. So the financial toxicity has to go down so the patient is affordable for all these things. Yeah, so this is one factor which I thought I should discuss.
Sure. Right. Thank you so much. And now we move ahead. So the next topic in the segment for hepatocellular carcinomas in this meeting is on the systemic treatment in advanced HCCs. What are the avenues that we have as of now? And to talk about this, we have with us Dr. Kshitij Domadia. Dr. Kshitij, hi. Dr. Kshitij is consultant medical oncologist at HOC Vedanta, Ahmedabad. Over to you, Dr. Kshitij.
Good evening, Dr. Rajat. Good evening, all my seniors and colleagues. Thank you for the invitation and bringing out quite a less discussed topic in HCC, and that also what to do beyond first line. So let me start by this classical BCLC staging system. And I just want to mention that BCLC stage C is exclusive domain of medical oncologists. Obviously, BCLC B, not amenable to loco-regional treatment, also is a medical oncologist domain as well. So some basics regarding the child PUG scoring system: 3 lab parameters, 2 clinical parameters. Lab parameters, it is albumin, prothrombin time, and bilirubin. And 2 clinical parameters, ascites and encephalopathy. And based on this, patients can be classified into one of the 3 classes: class A, B, and C. Class A, if the patient is having 5 to 6 points, class B 7 to 9 points, and class C 10 and more than that. So what factors which one should consider before thinking of any second line treatment? Obviously, the most important thing is the performance status of the patient, the child PUG scoring of the patient, what prior treatment the patient has received, what regimen we are choosing, what is the response rate, what is the overall survival of that particular regimen, and obviously what is the toxicity profile of that regimen. So if we see till few years back, we only had sorafenib in the first line management of HCC, then came lenvatinib, and then came atezolizumab, bevacizumab. Now we have 3 options basically in the first line management, that is sorafenib, lenvatinib, and atezolizumab plus bevacizumab combination. And if you see the second line options, broadly I can divide it into NIPS, the TKIs, the regorafenib and cabozantinib, the VEGF receptor monoclonal antibody ramucirumab, and the third part is a checkpoint inhibitor, and that includes both monotherapy as well as the IO-IO combination. That is nivo-pembro as monotherapy and IO-IO, that is nivo plus ipilimumab combination. So over the next couple of minutes, I would like to discuss amongst the second line, these second line options and how to go ahead with that. But prior to that, just one side on assessing the tumor response on any TKIs. As we all know, these TKIs, they are basically cytostatic, they're not cytotoxic. So the conventional RECIST criteria is not very accurate in determining the disease status of the patient. There is something like a modified RECIST, which takes into account the tumor viability, as well as we can monitor the alpha-fetoprotein into it. So we can discuss with our radiologists to use this particular criteria in defining the responses on any TKI. So if I can just start the discussion comparing the three important second line options, that is regorafenib, cabozantinib, and ramucirumab. Let us see the similarities between these three and let us see the differences between these three. So the trial of regorafenib was Resource, cabozantinib was Celestial. The both are oral agents. Ramucirumab REACH 2, it's an IV agent. They all are phase 3 trial. They all had comparator arm as placebo. They were all second line trials. They all had a median overall survival in the range of 8 to 10 months. Hazard ratio 0.6, 0.7. If we see the differences, let us focus on the first, that is regorafenib. The difference, and one more similarity, they all had only CTP-A, no B, no B7, and C is just out. So if we see the differences, let us focus on the regorafenib trial, that is Resource trial. It included patients who were tolerating sorafenib well. At least 400 milligrams of sorafenib were tolerated, should be tolerated well in the prior line. So if because of any reason, because of intolerance, if we want to change the treatment, regorafenib is obviously not a good option. If you see cabozantinib trial, that is Celestial trial, it included even patients in the third line. At least 20-30% of the patients were in the third line as well. If you see the ramucirumab trial REACH 2, it included patients whose baseline AFP was more than or equal to 400 nanograms per ml. So these are some of the similarities and some of the differences between these three important second line treatment options: regorafenib, cabozantinib, and ramucirumab. Now, when you have agents with similar efficacies, no head-to-head comparison trials, then looking into the toxicity profile makes sense. So if we compare the toxicity profile of these three agents, we can just make out from the picture that ramucirumab is considered to be as the most tolerable one. Only hypertension, which is there in the dark. Regorafenib and cabozantinib being a multi-kinase TKI, they're having problems common to all the TKIs: skin toxicities, rashes, mucositis, diarrhea, hypertension, fatigue, transaminitis, etc. And if we just compare regorafenib and cabozantinib, I don't think this is the right way to do it. You can see cabozantinib more colored one, the color of cabozantinib subset. Anyways, sorafenib and lenvatinib, we generally, these are the agents we use in the first line setting. And in the last year, we have an option of atezolizumab, bevacizumab in the first line. Unfortunately, we don't have any good data on what to do post atezolizumab and bevacizumab. One of the thoughts is, if we are using this combination in the first line regimen, can we use the typical sorafenib and lenvatinib in the second line? We don't have good quality evidence to support what to do, but this is one of the retrospective analysis from 3 centers in Asia, and it did mention the use of lenvatinib, sorafenib post atezoli bev. And looking into it, lenvatinib fared slightly better than sorafenib in terms of median PFS as well as the overall response rate. So that was in brief regarding the TKIs and ramucirumab. Now let me focus on the checkpoint inhibitor part. Let's start with nivolumab. So nivolumab was studied in HCC as a phase 1, phase 2, initial phase 1, phase 2 trial, checkmate 040 in child PUG A and B patient. Basically, there were two cohorts. There were the dose escalation phase and the dose expansion phase. And it included patients of both the first line as well as the patients who had received prior sorafenib. And if you can see from this spider chart, in all the subset, there was response to the tune of 20%. And most importantly, if I can point out is, let us point out on these part. These are the patients who got complete responses. So if the patient is lucky, or more importantly, if you are lucky, you may get these complete responses with immunotherapy agents. And if we can see, it is just not the responses. These responses are translating into good survival benefits as well. So this was a trial which led to an accelerated approval of nivolumab in both the first and the second line setting. If you see the PD-L1 expression, I can tell you, as far as HCC is concerned, forget the PD-L1. That actually makes our lives much easier than lung. Don't forget just PD-L1 in HCC. If you see the child PUG B cohort, nivolumab, it is having a response rate of about 12.1% with a disease control rate of 55.1%, even in the child PUG B cohort. Next, nivolumab. So after this particular trial came a study, that is segment 459, in which nivolumab was pitted against sorafenib in the first line setting. And if you see the primary endpoint overall survival, the median overall survival for nivolumab was 16.4 versus 14.7 month. Hazard ratio was 0.85. The upper limit of the confidence interval was 1.02. Slightly missing the mark. It's unfortunate for nivolumab, but if you see the response rates, nivolumab had response rates of 15% versus 7%. So because of this as a negative trial, if you see the NCCN Hall of Fame, and if you see the position of nivolumab monotherapy in this particular chart, in the second line or even the first line, it is pushed to the right hand corner, and it is a category 2B recommendation as of now. Now, let us focus on the IO-IO combination, that is checkmate 040. Okay, so this was a trial in advanced HCC. Patients had received prior sorafenib. They were either HBV or HCV infected. They had a CTP score of A, no B was there. Performance status 0 and 1, no performance status 2 was there. And the subjects were randomized into one of the three arms. All these three arms differed on the dosing regimens of nivo-ipilimumab. If you see arm A, it was nivo 1 versus ipilimumab 3 every 3 weeks for 4 doses, followed by nivolumab 240 mg every 2 weekly flat dose. Arm B was the reverse, nivo 3, ipilimumab 1 for 4 doses, then nivolumab. And arm C was nivo 3 every 3 weekly and ipilimumab 1 every 6 weekly. So these arms differed based on the dosing regimens of nivo-ipilimumab. And if we see the response rates amongst these arms, they were nearly 32%. But if you see the overall survival rate, arm A, median overall survival was 22.8 months. 22.8 months. And we are talking of HCC. And that is really phenomenal. Arm B, 12.5, arm C, 12.7 months. And most importantly, I had mentioned previous, if the patient is lucky, more importantly, if you are lucky, you may get complete responses. And if you see this part, 1 year overall survival rate was 61, 2 year OS 46, 3 year 42. So 2 year OS rate 46, 3 year OS rate 42. That shows the durability of the responses with this combination. So every good thing comes with a cost. That's a rule of nature. So there are obviously concerns of safety with this particular regimen. If we see grade 3, grade 4 toxicities in arm A, 53% versus 29% versus 31%. And any grade, nearly everybody is having. some of the other toxicities with this particular regimen. That is important to be mentioned. As far as HCC is concerned, giving IO, we should be having very low threshold to detect immune-mediated hepatitis. You see, the AST increase, any grade 20%, out of which 16% they are grade 3, grade 4. So the threshold to pick up any immune-mediated hepatitis should be more when you're giving IO in HCC patient. Okay, so that was about nivolumab.
Dr. Kshitij, sir, brilliant presentation as always. Last 3-4 minutes to conclude, please.
Sure. Just about to complete it. Now, the story of pembrolizumab. It started with Keynote 224 as a phase 2 trial, and then it was studied in Keynote 240 as a phase 3 trial. It was compared against placebo. And if we see the median OS, pembrolizumab room 13.9 versus 10.6, hazard ratio 0.77, p-value 0.0112, whatever. Because of some statistical juggle, it is not considered to be as a significant one. This particular trial, just mentioned beautifully just previously, it was presented in this year ASCO, Asian subset, pembrolizumab plus bezapotiricab versus placebo plus bezapotiricab in the second line setting. We see the median OS 14.6 versus 13. It is considered to be as significant, but this doesn't really excites me to give pembrolizumab. If we see the level of evidence is not that much high. The clinical benefit is also not that much seen. So if you see, it's not the main player. It is a substitute as of now. If you see the NCCN recommendations as well, if you see the monotherapy pembrolizumab is considered to be as a 2B recommendation. So, I just concluded. The thing is that whatever evidence we have in the second line is post-sorafenib. We don't know what to do after atezolizumab plus bev. Can we use sorafenib, lenvatinib? We don't know. Even we don't know what to give after lenvatinib. Can we use sorafenib or any other things? We don't have any good quality evidence for that. So these are our knowledge gap. What to do after atezolizumab? What after lenvatinib? Can we use IO post atezolizumab? That will be answered, I mean, in a couple of months or couple of years. How to sequence these second line options? What dosing regimens to use if you're choosing IO? I think these are some unsolved queries. These are our knowledge gaps. So take homes is see the CTP score in all. Just best supportive care if the CTP is C. Post, if you're using atezolizumab, bev in the first line, choose one of the NIBs. I think you can use sorafenib and lenvatinib post atezolizumab bev. If you're using sorafenib or lenvatinib in the first line, and if the patient is progressing, then the next best option is use a checkpoint inhibitor. And as far the data is concerned, IO plus IO data is far better than the monotherapy. That to be preferred over NIBs. Don't just remember the few CR rates with checkpoint inhibitors which can be done. Post first line sorafenib, can we use atezolizumab? Again, I don't know, but probably you can extrapolate and we can use it till we have a definite answer. Avoid IO in post liver transplant because of the risk of allograft rejection. Have a low threshold for immune-mediated hepatitis. Because of lack of time, I haven't mentioned the chemotherapy regimens, but these are the regimens which are tried in advanced HCC in later lines. Use modified resistance, discuss with your radiologist for this. Check anti-HPC as well and involve your gastroenterologist. With this, I thank the organizers, thank Dr. Rajat and all the organizers for giving me this opportunity. Thank you.
Thank you, Dr. Kshitij. A very crisp presentation. Dr. Amish, sir, in the chat box is asking if TK is used in the first line, then in second line, what to use, Nivo versus atezo-bev combination?
So again, if I used TKs in the first line, suppose I've used lenvatinib to start with, we don't have any good quality evidence, but I will consider using atezolizumab because it's having a very good first line data evidence. So I don't have any problems using it in the second line as well.
So
okay.
Can I,
Yes,
Dr. Rajat, so can I make a
please.
quick comment? Yeah, so
Yes, good evening, sir.
Dr.
Yes, sir.
Hi, good evening, Dr. Kshitij. It's a
Yes, sir. Good evening, sir.
great pleasure seeing, hearing
too,
to you
sir.
after such a long time. So it
Me
was
too, sir.
really nice and crisp presentation. In the interest of time, I will just make 2 quick comments and 1 quick question. So as you said, as per your crisp presentation, you said the 2 pillars of HCC treatment are either TKI or IO combination or single IO agent. But now, as the science is evolving since last 2 years, we have a lot of trials undergoing, like Himalaya trial with which is trying pembrolizumab plus lenvatinib, or cabozantinib plus atezolizumab cosmic trial. So once these results are out, I think these 2 pillars will combine. So we will have a IO TKI combination data will be coming up in soon. So that was first comment. Second quick comment I just wanted to make, I'm not a very big fan of ramucirumab, and you can correct me if I'm wrong. Sorry, cabozantinib. So I think celestial trial which you told that the cabozantinib tolerability is not good, I truly accept that. But the patients included in those subset were both those who has transaminitis and high bilirubin level. So means the patient population of celestial trial was not very good. That's why the tolerability profile of cabozantinib was not found better. This is what I feel. Otherwise, I am not a very big fan of cabozantinib. And my 1 quick question is, so as per after your such an extensive presentation, I would just like to ask 1 quick question, that where would you place single agent nivolumab in present HCC treatment? I think I'm just Amish sir, what Amish sir has asked, I'm just extrapolating it. Yes. Single agent
definitely. So definitely, so personally, I think that Nivo plus ipilimumab combination, the data seems very good, but the dosing regimens, we don't know the exact dosing regimens. We don't know how to deal with the toxicities. So till we have good knowledge about the IO combination, how to use this, I think it's fair enough to use nivolumab till then. So definitely in the second line, I would like to use it.
Yeah, second line nivolumab. So that's what sir asked us. So I just wanted to say that we have to think very practically that if patient has already received lenvatinib, most of these patients, they might not be fit enough to receive a IO combination, and these are the patients where I landed up using single agent nivolumab in my practice. So this is, I think sir wanted to say something. Yes, sir. Thank you.
No, thank you, Dr. Kshitij. It's a very nice, crystal clear presentation.
Thank you, sir. Yes.
Just, Nivo EP combination is not as bad as, people think. If you see EP initially followed by Nivo, so if somebody is fit for Nivo, and if you don't have an issue with diarrhea or skin toxicities, I think Nivo EP, given the data, Dr. Kshitij, if the patient agrees, because it was a phase 2 data and is still not in the FDA, this thing, excellent data. Would you agree, Dr. Kshitij? I feel that outside the setting of a clinical trial or a legally non-compliant patient, if the patient is with you for a longer time, I think Nivo EP post TKI or post lenvatinib can be a very good option.
Absolutely agree.
One of the other thing, Dr. Kshitij, what I wanted to share with you, I might have missed that slide. Sorafenib followed by cabozantinib. Also, if you see patient responding more than 6 months, have given as close to almost 40 months survival, 39-40 months survival. So I think that also can be one of the second line option if patient has responded beyond 6 to 8 months for sorafenib.
Yes, so exactly my point I was about to make, that we do consider the PFS in the first line in RCC. Why should we not consider the PFS in the first line in HCC?
Correct.
So we have that we have had a good response to a VEGF inhibitor. Why not, subject the patient to another VEGF inhibitor or a multi-TKI for that matter in the second line, rather than jumping onto a IO or rather an IO plus IO combination. So that also needs to be kept in mind while we are sequencing drugs in HCC.
That was celestial population which sir is talking, I think.
Yes.
Post sorafenib, so that we have evidence for the same, as we all are on the same boat.
Yeah. Right. So thank you, Dr. Kshitij.
Yeah, Dr. Rajat, we are running short of time.
Yes, we now move on to now move on to the next session, which is on rectal cancer. And in rectal cancer, we have the big debate. And this debate is on how to really treat rectal cancers in 2022. One is whether we should use the conventional therapy, which is the neoadjuvant chemoradiation, or we should use the total neoadjuvant therapy. And to debate on these two topics, we have with us two debaters who are stalwarts in their own fields, Dr. Kripa Shankar, medical oncologist from Coimbatore, and Dr. Vinita Goyal, head of radiation oncology in Fortis Hospital, Shalimar Bagh. So I'll start with Dr. Kripa Shankar for his part of the debate, and then it will be over to Dr. Vinita. Dr. Kripa Shankar, good evening, sir. Please go ahead.
Yeah, thank you, Rajat. Let's share my screen and we'll get started right away.
Yeah.
Hope my slides are visible and I'm audible. So a very good evening. Yeah, thank you, Rajat. So a very good evening and a warm welcome to everyone. And at the outset, before I begin, I'd like to take this opportunity to congratulate the organizers for putting together this wonderful conference and also thank them for the opportunity. So I think we're all set for the big debate today, which is on TNT, total neoadjuvant therapy versus conventional chemoradiation. But my question was, when I looked at the debate, should there even be any debate at all? I think TNT has already become standard of care. And I'm really glad that I'm not on the other end. I'm talking for TNT. So I think there absolutely is no debate on this. And when you look at history also, and what it has taught us over the period of years, is that we've started with adjuvant radiotherapy, and then we realized that neoadjuvant radiotherapy was much better. And so on and so forth. Even if you look at the data for adjuvant chemotherapy, that's very weak. And what we have seen is the neoadjuvant strategy has actually led to better outcomes over the period of time. And currently we are in the era of total neoadjuvant therapy, and that's become the standard of care. And the future will be watch and wait, which I'll be touching on later as well. So if you don't learn from history, I think we'll end up making the same mistakes over and again. So if you look at how the NCCN puts it, or even if you look at this concept called the good, the bad, and the ugly of rectal cancers, we know anything up to T2 is probably good subset, where even stage surgery is absolutely feasible. Anything with T3 or N positive becomes bad, and T4, and or if the CRM is threatened, or if you have the MRF misrectal fascia being involved, then it's an ugly subset of tumors where they become locally unresectable. So I think there is no debate on the good subset. The point that we're trying to debate today is only on the bad and the ugly subset of tumors. So I just wanted to make that very clear. And obviously, there's just no one size that does fit all. So you'll have to really find a tailoring treatment according to the patient's presentation, be it a good, bad, or an ugly subset of tumor. And again, I think this is the subset that's most likely to benefit from total neoadjuvant therapy. That is the patients with a poor prognosis who fall into the bad and the ugly subset of tumors, who have a CRM of less than 1 millimeter, or low rectal tumors where the intersphincteric plane is involved, and anything T4 or EMV, extramural vascular invasion present on an MRI, and N2 or lateral lymph nodes. I think this is where TNT has really made an impact in this subset of patients. So let's look at a bit of history again. This is what the standard of care was probably a couple of years back, before ASCO 2020. We could do long course chemoradiation and then delayed surgery by up to 8 weeks. Short course RT and immediate surgery has almost gone out of vogue. It's not gone out of favor because the short course RT only ends up sterilizing the margins. Whereas if you want downsizing and downstaging, you would really have to give long course radiotherapy, or you'll have to wait for at least 8 weeks. So I think that's where the concept of TNT actually came in. Because when you actually wait for 8 weeks, you don't have to just keep doing nothing. You could actually end up giving them chemotherapy in the interim period. So I think, my clear consensus on this, and also my message to my opponent, would be don't focus on the past or you'll miss out on the future. And this was the Stockholm 3 study, which looked at delaying surgery by up to 8 weeks after short course radiotherapy. And that study did show us was that there was an improvement in the path-CR rates when you did that. But again, the recurrence-free survival and the overall survival is not much to choose from, but the path-CR rates were higher. So let's look at adjuvant chemotherapy and the data that we have currently. There is absolutely no level 1 evidence. There's not a single phase 3 RCT that has actually been positive for adjuvant chemotherapy. If you look at the DFS and the overall survival, as I've shown you here, agreed, yes, there have been a lot of criticisms. They've all been old studies, very poor accrual and suboptimal chemo regimens and poor compliance, all of that agreed. But having said all that, there's not one single phase 3 RCT or level 1 evidence for adjuvant chemotherapy. So, which again, I would really ask my opponent, show me the data for real adjuvant chemotherapy here. And this is probably the best of what we have. This is the phase 2 data called the ADOR trial, which looked at 5-FeLV versus FOLFOX. And yes, in patients with stage 2 and stage 3, there was a DFS benefit to the tune of around 8 to 9% absolute difference. So let's then look at the recommendations for adjuvant chemotherapy after pre-op short or long course chemoradiation. What is striking for me is that then you'll have to talk to the patient and inform them about a lack of robust data and discuss the pros and cons of observation versus adjuvant chemotherapy. Key statement. And stage 0-1 observation, again, otherwise single agent 5-FP or capecitabine. And even if it's stage through, you still have to discuss the pros and cons of either doing single agent or doublet. So I think this is more like, anything goes, and there's absolutely nothing that anyone can draw concrete evidence from. So let's move to the present. And what are the new standard pre-op regimens after ASCO 2020? Well, we've seen that distant recurrences are a major challenge. Earlier delivery of systemic therapy, like, for example, moving from adjuvant to neoadjuvant chemotherapy might solve the risk and might decrease this risk. And that's where these two strategies come in, where we do induction chemo followed by long course chemoradiation or short course chemoradiation followed by, and I think probably that's the area that we would actually be debating on. Would you want to start with chemoradiation and then sandwich chemo in between, or would you want to start with chemo and then do chemoradiation? Because as far as I'm concerned, TNT is here to stay. And that's why it's become the new standard of care. So I think it's very important for us to live in the present. I think, Trump is no longer the present, so Joe Biden. So I think, it's very pertinent for us to believe in the present. So this was the Rapido study. Again, if you they looked at patients with high-risk rectal cancer, either had CRM positive, T4, N2, or lateral lymph nodes being positive, or EMVI. And look at the PAT-CR rates. There was a doubling of the PAT-CR, 28 versus 14%. And the primary endpoint of disease-related treatment failure was also met. And again, if you're going to harp on toxicity, I'm going to clearly put it, that's why I boxed it. No difference in the post-op complications and quality of life. And let's look at the other TNT trial, which is the Prodigy 23 trial. And again, they looked at patients with stage 2 to 3 rectal cancer, where they started with chemotherapy, followed by chemoradiation, and then surgery. And again, as you can see here, clearly there was a doubling of pathological CR rates, and the primary endpoint of 3-year DFS was also met, an absolute improvement of around 7%. Here, interestingly, there was a reduced risk of post-operative complications with TNT. And again, there was no difference or no deterioration in the quality of life. So to my opponent, have you had enough? Well, there's more to come. Well, again, to add to those two studies, we have another phase 3 study called the Stellar study, which we've had the results from as well. And that's also met its primary endpoint. And as you can clearly see here, has also shown an improvement in 3-year overall survival of around 10%, absolute difference. And then the Polish study, the Buchko regimen, as we call it, which actually led to all these TNT strategies coming in. So there's no such thing as too much data. And let's just have a brief comparison between the Rapido and the Prodigy 23 trials. So if you look at it, patients on the Rapido study had much more aggressive disease, more T4 disease, more N2 disease, and also most of the patients, around 2/3 of the patients had MRF involved as well. So this was a slightly more higher risk subset of patients that were included in the Rapido study. I agree these are only cross-trial comparisons, but still just for us to understand as to how TNT should actually be done. So again, the PAT-CR rates, I think there's no doubting that. There was definitely an improvement in the PAT-CR rates when you did TNT. It was almost double. So I think it's time for me to put the final nail into the coffin, because I'm sure my opponent will argue saying that, but does the PAT-CR actually translate into a better survival? And this is the data that actually clearly tells you that, yes, having a PAT-CR does translate into a survival benefit. And not just in terms of local recurrence, but also in distant metastasis-free survival, DFS, and overall survival, as you can see here. Wait, I'm not done yet. So let's look at the last part of it again, which is again on response assessment. And can you actually do away with surgery as well? How could you do that? Could that be a subset of patients where you could just do a watch and wait strategy? And again, you look at using the MRI tumor regression grading scoring system, and then you have your imaging, endoscopic aspects, and clinical examination as well to qualify them as having attained a clinical and radiological CR. So this is the international watch and wait database. So this was actually set in motion by, the earlier studies by Agilita Haber-Gamma, who's considered to be, the forerunner of all this watch and wait strategy. And well, this is not something which is a work in progress. As you can see here clearly, the 2-year local recurrence rates range from around 20 to 30%. Agreed, it does need a stringent protocol. I'll show you that as well in my next slide. And with salvage surgery, you're able to salvage almost around 80 to 90% of them. So I think that is, I'm sure my opponent, that would probably be my opponent's reaction, but don't worry, I'm not done. So these are the long-term outcomes after watch and wait protocol. So around 25% can fail at 5 years, and 8% can have distant metastasis. But this is key. The overall survival at 5 years, 85%, and the disease-specific survival going up to 94%, meaning most of them can be salvaged even if they have a local recurrence after the watch and wait protocol. So I think that's the future, and the future is already here. So, and as far as, can you do it in practice and how do you do it? This is how you would do it. You would have a digital rectal examination and a CEA once in 3 months for the first couple of years. And you would also need to do a flexible sigmoidoscopy once in 3 months, at least for the first year, colonoscopy at 1 year and then at 5 years, and then imaging once in 3 months for the first year and then 6 monthly. So I think, yes, this is how it's done. And I'm sure my opponent will also say, is it safe? Can you do it? Has it been done in trials? Well, this is the OPRA study, a phase 2 data, again, which looked at organ preservation. So the primary objective was survival, and the secondary endpoint, again, being organ preservation. And interestingly, and both the arms had TNT, or it was either consolidation or induction chemotherapy. And patients who were on the consolidation chemotherapy arm, around 60% could actually end up having this organ preservation strategy. Whereas induction chemotherapy, it dropped to 40%. So I think that's probably a more interesting debate, where we look at patients who actually receive consolidation chemotherapy could actually have, they have a higher percentage of achieving a clinical CR and a radiological CR, and thereby being eligible for organ preservation. So this is how it's going to look like, and this is how it's already looking like, and in the near future as well. So low risk, no doubt about that. I think it's straight surgery. We're not going to debate that. The intermediate risk and the high risk, TNT, absolutely yes, that's the way to go forward. And if somebody, and if you have a higher chance of reaching a clinical and a radiological CR and a path CR rates are high. So yes, I think you would definitely opt for that strategy. And remember, I'm sure patient preference really matters here. I'm sure a lot of us would have seen it in practice as well. A lot of these patients with low rectal cancers, where they would really look at avoiding a stroma, or sphincter preservation is not possible. So I think that the wait and watch protocol is definitely a very valid strategy in those patients, for sure. So I think that's the new normal, and that's absolutely good as far as I'm concerned. And that's what the NCCN says as well. This is the bad and the ugly subset of tumor. They've already made TNT, or total neoadjuvant therapy, has become the standard of care. And it doesn't matter where you choose, the Rapido or the Prodigy, but that's already become standard of care as far as the NCCN recommendations are concerned. So I guess this is the end for neoadjuvant chemoradiation alone. So I think this is how it is. Conventional chemoradiation has actually had a slip and fall, and it's time for it to rest in peace. And I'd like to offer my heartfelt condolences on writing this obituary for Lonca's chemoradiation alone. And with that, I'll pass on the baton to my opponent to continue with the commiserations on the demise of conventional chemoradiation. Thank you.
So I think very strong points coming through from Dr. Kripa Shankar, and I'm sure the next part of the debate, Dr. Vinita Goyal has got equally strong points. Dr. Vinita Goyal, ma'am, good evening. So over to you, and I'm sure you will be able to counter all these and many more.
Well, thank you, Dr. Bajaj, for giving me an opportunity to participate. And I know it is mainly medical oncologists who are present in the audience. It's a biased audience. But I sometimes really like the overconfidence of our medical oncology colleagues. Look at what Dr. Kripa Shankar has shown. Adjuvant chemotherapy was not working. So they said, okay, let's change its location. Let's give it in the neoadjuvant phase rather than adjuvant phase. So I think he has shown all the data that I'm going to show you now again, but he showed you selective results, and I'm going to show you the other side of the coin. When this debate was given to me, I immediately thought of the war which is going on, and I will leave it to you to decide who's Putin and who's Zelensky in this debate. So TNT, as we all know, is a relatively new paradigm which says to intensify the preoperative treatment by delivering both radiation therapy and chemotherapy before surgery. And the basis for this is the hypothesis is that moving chemotherapy from adjuvant to neoadjuvant setting will improve the compliance of the treatment and will also allow early and more efficient targeting of the micrometastasis. And because there's a time gap between radiation therapy and surgery which is getting prolonged, so the time-dependent effect of radiation therapy on tumor regression might also be better. And all this might translate into better path CR rates, which in turn might translate into overall survival benefit. So as Dr. Kripa Shankar has already accepted, I want to re-emphasize that while there is an overwhelming evidence in support of using adjuvant chemotherapy in colon cancer, but the corresponding corresponding evidence in rectal cancer is much weaker, and what we need is more effective drugs rather than changing the position or timing of the chemotherapy. So let's quickly look at the evidence for TNT. So this is the first trial which I wanted to show you, Buchko et al. Polish 2 trial. All of us know about this trial, which tested the two arms, comparing short course RT followed by consolidation chemotherapy followed by surgery versus conventional long course CTRT followed by surgery. And at 3 years, it showed that there was a survival benefit. After many years, we had a trial in rectal cancer which showed survival benefit, and majority of us were willing to change our practice based on the results of this trial. Dr. Kripa Shankar forgot to show you the updated results of this Polish trial, which at 8 years has shown that the survival advantage is not there on a longer follow-up. Dr. Kripa Shankar, please pay attention that while you were harping that there is a survival advantage, the Buchko trial, the Polish 2 trial, did not show overall survival benefit on a longer follow-up. Then we had two much awaited trials, one of which is Rapido trial, investigator-initiated study, multi-center international study, which again tested short course radiation therapy. Following that, there were 6 cycles of K-POX or 9 cycles of FOLFOX, followed by surgery. Here the surgery is happening at around 24 to 25 weeks after short course radiation therapy versus the standard arm. The standard arm included long course CTRT followed by surgery. Dr. Kripa Shankar forgot to tell you that here in the standard arm, adjuvant chemotherapy was optional. All patients did not get it. It was as per the institutional policy. Now, the Rapido trial did include very advanced stage tumors, as he correctly pointed out. Majority patients had at least some high-risk factor like T4A or T4B disease or extramural invasion or lateral pelvic lobe lymph nodes, etc. When we look at the results of this trial had a unique endpoint. The primary endpoint of the trial was a unique endpoint. It was disease-related treatment failure. And the trial did show that at 3 years, there was a 7% statistically significant disease-related treatment failure was better in the experimental arm, which included short course RT followed by consolidation chemotherapy versus standard neoadjuvant CTRT. This trial also showed that the distant metastases in the experimental arm were lesser as compared to the standard arm. But surprisingly, the local failures in the experimental arm were higher as compared to the standard NACTRT arm. It was not statistically significant, but the overall survival was same. There was no difference in the overall survival. This study did show that the pathological CR was double in the arm receiving short course RT followed by consolidation chemotherapy. Now let's look at the primary endpoint of the study. The unique primary endpoint for this study was disease-related treatment failure. Look at the local recurrences. At 3 years, the local recurrences were 17% in the experimental arm as compared to 10% in the standard of care arm. So if you look at the Rapido trial very closely, what we find is that in the planning of the trial, the original primary outcome was DFS, which was later on changed to disease-related treatment failure after starting the patient accrual, and the predefined target difference was reduced from 10% to 7% in due course of time. DRTF is a new non-validated endpoint. Adjuvant chemotherapy was not given in 40% of the patients in the standard arm because the participating institution did not believe in it. So there was definitely an imbalance in the two treatment arms. Around 1/3 of the patients had upper rectal cancers, where anyway the role of CTRT is not very well established. So what are we chasing? Are we chasing PAT-CR rates? And in this higher PAT-CR rate, is it because of more effective chemotherapy, or is it because of longer gap between radiation and surgery? And at what cost are we achieving this higher PAT-CR rates when we already know that increasing delays in surgery after radiation therapy is associated with more surgical morbidity? Counterintuitively, while the PAT-CR rates in the experimental arms were higher, the local recurrence rates in the experimental arm were also higher, which is not easily understandable. So where are we with Rapido? It has higher PAT-CR rates, lower distant metastasis, better DFS, but all these are weak primary endpoints, and 3 years is a short follow-up. The local recurrence and the distant metastasis actually start appearing after 3 years. So without any additional benefit of local control rate and overall survival, and with more toxicity, convincing patients on the benefit of this experimental arm or TNT, I think would be very, very difficult. Dr. Kripa Shankar also talked about another trial which came last year, Prodigy 3, which used more intensive chemotherapy in the experimental arm. They compared long course CTRT followed by surgery, followed by adjuvant chemotherapy with neoadjuvant 6 cycles of modified FOLFIRINOX, followed by long course CTRT. The time gap between surgery and CTRT was similar in both the arms, followed by adjuvant cycle of 3 cycles of FOLFOX or Xelox. So there was a basic, difference in the design of the Prodigy 2 and Rapido, which I think he has already discussed. And these were the clinical characteristics of the patients who participated in the Prodigy 23 study. Majority patients had advanced tumors. I agree that the tumors were less advanced as compared to the inclusion criteria of Rapido trial. And the primary endpoint of Prodigy 3 again was 3-year disease-free survival, and the secondary endpoints were overall survival and other factors. Let's look at the results. The results are quite comparable to how it was in the Rapido trial. This study also showed that there was a disease-free survival advantage with the use of neoadjuvant or TNT protocol, while the overall survival, metastasis-free survival, and cause-specific survival were similar in both the arms. However, the pathological CR rates were again double. Now, let me also talk about the toxicity of FOLFIRINOX. We have been using FOLFIRINOX sometimes in our patients who have locally advanced pancreatic cancers. And I think every time in the tumor board, there is a discussion whether the patient would be fit for FOLFIRINOX or not, because it is a more intensive chemotherapy. And in this study also, they found that 46% patients in the experimental arm had grade 3, grade 4 events. So the toxicity of the FOLFIRINOX is something to be thought upon. And you cannot generalize the use of FOLFIRINOX easily in all your patients. Now, following this, there is also a systematic review. There are several systematic reviews on TNT. I have chosen the one which was published in 2021, which includes all the studies, important studies, like, for example, the study by Butchko et al., Rapido, as well as Prodigy study. So there are 8 trials, including about 2,000 patients. This meta-analysis also showed that TNT only improved DFS and distant metastasis-free survival without any impact on the overall survival. So where is the evidence? What were you showing, sir? You were saying that there is no need of more evidence. We are pretty sure, based on this evidence, that at 3 years, TNT is not giving better results with either of the approaches. You use short course RT followed by more chemotherapy, more intensive chemotherapy, long course CTRT. Where is the evidence? The evidence is not there for overall survival benefit. He showed you NCCN guidelines. Let me show you ESMO guidelines. ESMO guidelines, in their whole schema of management of locally advanced rectal cancers, only talks about a TNT approach as a second option after conventional long course CTRT in locally advanced tumors. So he did talk about OPERA study, which I completely agree with. That OPERA study used neoadjuvant chemoradiation 2 regimes, either with induction approach or consolidation approach. And at 3 years, it did show, this is a phase 2 study, it did show that 60% patients could avoid surgery through watch and wait protocol, which I think, we need more data to bring TNT to practice, having more phase 3 trials, testing the approach which was tested in the OPERA trial of watch and wait strategy. So my own take is that NACT itself is a flawed paradigm, and TNT is an extension of this flawed paradigm. It should not be routinely applied. It may be a good option for patients who remain unresectable after NACT-RT. Its application, especially in younger patients, especially patients who have non-adenomahistologies like signet ring or mucinous carcinoma, needs further caution. We do not still know what is the right strategy or sequencing of CTRT in TNT. It is yet to be defined. We need more follow-up. We need more trials with larger number of patients to check the survival benefit. We need more phase 3 data like OPERA study on organ preservation protocol rather than focusing only on DFS and OS benefit or PAT-CR. What are we doing? Are we chasing PAT-CR or are we chasing survival? We need to clearly know. So I think I shall leave it to you to decide who's Putin and who's Zelensky in this debate. The whole world is saying to choose your leaders wisely. I would say in the oncology conference that choose your treatment protocol wisely, keeping the correct endpoints in your mind. Thank you. That's all from my side.
Thank you, ma'am. Again, like I said in the beginning, that there is going to be counterpoints by Dr. Vinita, and this is what it is. So just 30 seconds for rebuttal, Dr. Kripashankar.
Thank you, Rajat. I probably won't even need 30 seconds time. Thank you. But anyway, great points, Dr. Vinita. But I think, I think you probably sort of missed the point that I was not against giving radiotherapy. I think radiotherapy is going to stay for sure. It's about what you do after that. Because you're going to wait for 8 weeks. Are we just going to sit idle, not do anything, not give the patient anything for 8 weeks? I think that's where the TNT really comes in. And like I alluded to earlier, we believe in the concept of good, bad, and ugly in rectal cancers. We're talking about TNT only for the bad and the ugly subset of tumors. We're not going to try and push it for everybody with rectal cancer or with upper rectal cancers, or even with the good subset where we know they're going to do well with even straight surgery. So I think absolutely right. We have to go ahead on a tailored patient-to-patient basis. But I think, you were trying to point out that the survival was not. But let me tell you, all these studies were powered to meet the primary endpoint, which was either disease-related treatment failure or DFS, and the primary endpoint was met. So that is what made all these trials a positive study. And you forgot to mention about the Stellar study, which is another positive phase 3 trial that's already been published and was also shown that TNT is here to stay. So I think, without any doubt, I would definitely look at offering it, and not just in terms of toxicity as well, because you're trying to talk about toxicity. I think if you could probably end up even avoiding surgery for a subset of patients, I think that really cuts down on the toxicity profile as well. And the quality of life was definitely not much better. That's what I'd highlighted as well. So I think I have no doubts in my mind that TNT is here to stay. So with that, I rest my case and over to Dr.
Yeah, I think in the end, I would like to say that both the debaters have expressed their views very nicely, and they've countered their points one-to-one, which is exactly needed in the debate. I think it is a win-win situation only for one person, which is the radiation oncologist actually, because we definitely are including radiation, be it the neoadjuvant chemoradiation or the TNT. The radiation has to be there. Of course, we are debating whether we should actually use TNT for all the rectal cancer patients, or we should really reserve it only for the worst type of rectal cancers. And I think the answer is that we should reserve it only for the worst type, which is T4 or it is N2, or if there is a threatened CRM. The other point, which is very important, is that if we have to wait for 6 to 8 weeks post radiation, why not give patients chemotherapy and try to see whether, yes, like Dr. Vinita said, that the adjuvant chemotherapy in rectal cancers is a little doubtful. So really, if we place it in the neoadjuvant setting, is it going to work better than what it does in the adjuvant setting? Of course, organ preservation is definitely a little debatable as of now. We may not be looking at organ preservation so soon, and we have to wait for more data to come in. But certainly the DFS, certainly the PAT-CRs, we are chasing PAT-CRs in breast cancer. We certainly should be looking at PAT-CRs in rectal as well. YPT0 N0 or a YPT1 N0, the 10-year DFS, the 10-year OS is to the tune of 85%, which is a lot in rectal cancers. So certainly we should do that. Schedule is questionable. Schedule definitely, because it has been seen in the OPERA study also that RT followed by chemotherapy, or if it is chemo followed by RT, the preference should be given to RT followed by chemotherapy, so that we have more time for the patient to be undergoing surgery, and then the beneficial effect of RT is seen. And of course, toxicity is something that we can manage as medical oncologists. So even with FOLFIRINOX, we can do the management of toxicity. So these are my points. Final word by Dr. Amish Vora, and then we go on to the next session, which is by him only.
So first of all, two things, Dr. Kripashankar, you do not know, but remember, never take pangas with Dr. Vinita Goyal. That is a saying in Delhi. Okay. But Vinita, I think we all are shifting our gears to TNT. TNT is here to say, as Krupa Shankar said, but you brought out a very important point. I must say that at least today, I will go back and again read Rapido and Prodigy trial and the phase 2 ATRA trial and the last trial. I forgot what Dr. Krupa Shankar said. But the point, I think one of the important points which coming out of this, Vinita, would you agree that at least the long course CTRT is better than short course, whether you use chemo or upfront or chemo later? What do you say, Vinita?
Looking at downstaging or downsizing of the tumor, then long course CTRT is certainly better. As Dr. Krupa Shankar said, that for ugly tumors, long course CTRT is better.
Why I raise that point in private practice, I have seen many a times people resorting to short course when the patient is really a case for the long course. So I think, as Krupa said, CTRT is here to stay. Whether chemo pehle de ya baad mein de, but RT is here to stay. I think TNT followed by organ preservation is going to be the key, what I feel in future.
Amish, when the results of Butchko or College 2 study came, and at 3 years they showed that there was an overall survival benefit by short course RT followed by consolidation chemotherapy. That is when some of us have changed our practice from long course CTRT to short course CTRT followed by chemotherapy. But now when at 8 years it is not showing the survival,
absolutely,
you are all going back. You are all shifting gears back.
Correct. Great. I think it is one of the wonderful debate, Dr. Bajaj. Really enjoyed and learned a lot from both of them.
Yes, right. Thank you so much, both the debaters. Thank you for a very nice debate. And so we now move to the next session, which is going to be by Dr. Amish Vora. Dr. Amish Vora, as we all know, is a prominent medical oncologist of the country. He is the director and co-founder of Hope Clinic in Delhi, and he's going to talk us through the biomarker-driven treatment of advanced colorectal cancers in 2022. Over to you, sir.
Thank you, Dr. Bajaj. I don't know about prominent, but Bhutta Jarur ho gaya hu, because 3 years back, people used to say Amish said this in webinar, Amish said this in webinar. Now people are saying Amish sir and sir. Vinita Bhutte to hum ho gaye hai, aisa lagta hai. Anyway, coming to today's topic, I will try to cover up because we are running little late. A very interesting topic which Dr. Rajat has given me. When the patient is in front of us in advanced colorectal cancer, there are 3 main large scenarios what we look at. Whether it's a resectable metastatic disease, whether it is unresectable metastatic disease, or potentially resectable in future following some treatment which we give to patient. Now, why do we have to discuss this topic? We have to discuss this topic because 5FU alone, we all know, is 10 months is overall survival. When we add either irinotecan or oxaliplatin, it increases to 22 months. When we add either bevacizumab or anti-EGFR, it increases to 30 to 36. Immunotherapy keynote 177 trial, the last reported the median overall survival in the experimental arm has not reached. I'm waiting, in case if somebody has seen the overall survival, can put in the chat box so we can learn. It's very simple. When we talk of 10-year overall survival in rectal cancer at 85%, in advanced colorectal cancer, 3 years, 3.5 years is not good enough. And we need to improve upon that. So today's topic I have tried because, the standard biomarker-driven management we all know. So I've tried to tweak around a little bit. And please let me know if something which I say doesn't make any sense. Biomarkers currently done in day-to-day today. PANRAS, we all know KRAS alone is not enough. You have to do KRAS, NRAS, that is PANRAS. BRAF 600E, MSI high or stable, and whether HER2 is amplified or not amplified. I think all of us are doing these 4 biomarkers. And I don't think that anybody can miss any of these markers. And if they are missing, please start doing that. What can be done? What are the potentials? One, PPD enzyme deficiency. Second is PD-L1 because, it's easily available on immunohistochemistry. Tumor mutation burden. And this is a very interesting thing. I'll just share some slides about that. Whether upfront NGS should be done or not, which will capture NTRK, tissue agnostic for larotrectinib and entrectinib, but only 0.5% of CRC. P10, PIK3CA, we really don't know what to do with these. Any TEAP or STK11 mutations, we really again don't know what to do with those. And the last but not the least and emerging is cell-free DNA on liquid biopsy, that is on blood. I will not talk about DPD enzyme deficiency going forward, but I have discussed this point with many national and international people who are looking after GI cancers. People are not doing this routinely. But if all of you can recall, those who have done practice for 10 years and above, we have at least one case on day 7 of 5-FU-based chemotherapy. Patients' neutrophil percentage, neutrophil count is less than 500, and many of these patients die. So I personally think that in a medico-legal era, DPD enzyme should be discussed with each and every patient for colorectal cancer who are to be started on 5-fluorouracil-based chemotherapy. I have started doing this in almost all patients. I have yet to get the first positive, but I have not got, after starting doing that, I have not got any grade 4 myelosuppression as well. So this is something which I think everybody should keep looking at that. Dr. Shyam Agarwal sir always says कि अमिश तूने NCCN तो दिखाया ही नहीं. So no topic can be complete without NCCN. NCCN says these are the 4 biomarkers which are validated as of today in 2022. That is RAS, BRAF, HER2, and MMR. These are the 4 things which are sort of standardized. Question is, should we do NGS upfront, or should we do RAS and RAF by point mutation PCR, HER2 by immunohistochemistry, MMR by immunohistochemistry? Can we miss out some of the mutations which are basically justified by giving treatment? So very quickly give one real live example. The 62-year-old male who's doctor by profession, right-sided CA colon, localized disease, post-op, there was a leak at anastomosis. The chemo was delayed by 60 days. 3 months after adjuvant chemotherapy, there was a progression at local site and liver, peritoneum. There was one nodule biopsied positive. MSI by immunohistochemistry was negative, BRAF wild type, HER2 non-amplified. What next is a question. FOLFIRI, within 3 months, just giving FOLFOX, within 3 months, 5 cycles, patient progressed. Really, FOLFIRI will work. Daughter of the patient was a doctor at, still as a doctor at University of Pennsylvania. She had some project going on at Mass General Hospital, New York. She sent her NGS there, and there was MLH1 mutation was seen. Talked with patient daughter and patient who's a doctor. We started on nivolumab. 2 days back, just 2 days back, patient completed 22 months of IO. 4 CT scans every 6 monthly, all in complete remission. My question is there a biomarker driven or NGS driven management? I don't know, but whether should we do upfront NGS in all metastatic patients is a question which we don't know. Since we are talking of MSI high, I thought let me complete that chapter of biomarkers. First line treatment in deficient MMR or MSI high, nivolumab plus ipilimumab or pembrolizumab alone is approved. You can use it as the first line in unresectable synchronous liver or lung metastasis only. This is based on Keynote 177. As I mentioned, there was a huge gap in the PFS and OS has not reached in the experimental arm. But remember, not all patients of MSI high respond. And you see the circle which is there in almost every IO treatment. There are some patients who are rapid progressors on immunotherapy, and we may lose these patients very fast. So let's look at these based on biomarker results. Assuming patient is MSI high, but BRAF is mutated and RAS is wild. Will the immunotherapy work? If MSI is high, BRAF is wild type, but RAS is mutant, will immunotherapy work? We do not have the clear-cut answer, but the first scenario with BRAF, it still says it will work. While if the RAS mutation is there, probably immunotherapy will not work. Data is still not mature, but these biomarkers are here to stay. Again, MSI high. Patient has MSI high by IHC. And person like me would love to dig into it details, and I would do tumor mutation burden. And TMB is either comes low or high. Will my choice of immunotherapy change? And let's look at this interesting data. There were 3, again, retrospective data. 22 patients in one study, 90 patients in another study, and 40 patients in another study. Very, very small number of data. But look at the TMB cutoff, what they have used, either 37 or 26 or 10. But the important point is look at the TMB low versus TMB high when treated with immunotherapy. The gap is so huge. And I really wonder that I have treated many patients of MSI high with colorectal cancer, and they all have done well so far. Unfortunately, I have not looked at TMB in these patients. I would like to go back and look at the TMB in these patients, whether they were actually low or high. But there is a food of thought in the studies. The last on MSI high, potentially resectable colon cancer with synchronous metastasis, MSI high on IHC. Will you give neoadjuvant IO? Again, good. Yes, of course. Why not? Because you can give neoadjuvant IO. You can look at the conversion rate of resectability at 2 months. And if the patient is resectable, go ahead and do the surgery. This is a very, very interesting paper in 2022 West Oncology Conference. And I came across this paper. It's a very, very interesting. There were 14 patients of MSI high who were treated with IO or IO plus IO combination. 13 out of 14 had radiologically persistent disease. But when these patients, all 14 were resected, 13 out of 14 patients had PAT CR. And one patient who had not PAT CR, only 1% tumor was positive. So the question is that could surgery be avoided in these patients in advanced MSI high colorectal cancer? This is an amazing data for me, especially to see many of these patients were labeled at Lynch syndrome. So that is a separate discussion. So to conclude on MSI high biomarker in a management of advanced colorectal cancer, you can't miss looking for MSI. Whatever method you want to do, but please, please, please look out for MSI. IO is approved in first line in MSI high. Concomitant BRAF and RAS mutations are also very, very important. And you have to keep looking at the data to see whether one does not respond to IO and other responds, or both do not respond to IO. NACT setting in limited Mets disease, IO can be a safer option, or in future, there may not be any surgery. Patients can have a long-term control. So keep looking for these spaces. Very quickly about the other biomarker mutations, and do let me know when I have 3 to 4 minutes left so I can conclude my topic. RAS mutations. It is always included in colon panel. Point mutations can be identified by PCR or NGS. Extremely important to look for K and NRAS both. One should not give cetuximab or panitumumab if these mutations are present. I am very sure 100% of medical oncologists in India follow this. But on the other side, this is somewhere some gap I have seen amongst the MO community. One should not miss anti-EGFR if there is a left-sided tumor and if the RAS is wild type. And this is based on the data which we all know: RAS wild type, left-sided, metastatic colorectal tumor, cetuximab given first, followed by BEV, highest survival ever seen. And we should not miss this opportunity. This is something which I wanted to say. Now, again, RAS may, there are double mutations. If there's a RAS wild type, but HER2/neu is overexpressed, what will you do? If the RAS is wild type, but BRAF is mutated, will you give anti-EGFR? In both the cases, I would say trade with caution. In the first case scenario, if the HER2 is overexpressed, it will not allow anti-EGFR to work. And if BRAF is mutated, we all know that you have to trade anti-EGFR with caution. This is what I'm talking of the data in the first line. So RAS biomarker in management of advanced colorectal cancer, we have a standardized test for RAS mutations. You don't have to worry about that. If RAS is wild type, but BRAF is also wild type, and tumor is on the left side, highest OS with anti-EGFR plus chemotherapy. If BRAF is mutated or HER2 is amplified, bevacizumab may be a better initial option. So BRAF V600E mutation present in 5 to 7% of MCRC, chemo doesn't work well, anti-EGFR doesn't work well. So we all know Beacon study has been touted as practice changing, but look at the PFS or 4.5, 4.3 months and overall survival of 9.3 months. Of course, much, much better than the control arm of chemotherapy, OS of 5.9 months and PFS of 1.5 months. But at least Beacon said that target BRAF and continue giving anti-EGFR, you may get a better result. But this is a biomarker-driven talk. So there are further molecular subclassifications. People try to subclassify this group in CMS1 and non-CMS1. That again, very interesting in vitro study. This is called as adaptive mutability. You have BRAF mutation, you have MSS, metastatic CRC, you prime the tumor cells with BRAF plus EGFR inhibition, and alas, what you see, increased expression of PD-L1 in the tumor. So this is an in vitro study. Does it justify in the in vivo? Again, a small study where encorafenib, cetuximab, and nivolumab was given to 22 patients. If you see, and you see the response, the disease control rate was 96%. And as compared to 9.5 months of overall survival in these 22 patients, the overall survival reached almost 17 to 18 months. Again, this is just a thought-provoking thing that the way lenvatinib and pembrolizumab is approved in pMMR in endometrial cancer, I think here also we will reach a stage where we can overcome the BRAF-associated resistance to the existing treatment. The last or second last point of my talk, cell-free DNA in cancer. Where are we? There are no clear-cut guidelines even today. ESMO also says more data is required. NCCN also says that at this point of time, they will not approve this. But GISCO this year had a very interesting thing. Alexei, this was the trial by Japan and presented in GISCO this year. And they found, this was 1,040 patients, stage 1 to stage 4. And they clear-cut showed that ctDNA negative grew very well compared to ctDNA positive in terms of PFS months after surgery. Very, very interesting data. Also, one of the important points about cell-free DNA positivity, that if you give chemo in a metastatic disease, say for example, oxaliplatin or 5-fluorouracil, and if your cfDNA continues to remain positive, are you increasing the resistance to the further and further, and are you modulating tumor microenvironment? Again, a very interesting thought process. My last part of my talk is HER2 new amplification. There is still no data regarding first-line treatment in fit patients for chemotherapy. In unfit patients, or if the patient does not want chemotherapy, yes, of course it is there. But remember, in NGS, if you have less than 8 copies of amplification, there is a clear-cut data. This may not be a driver mutation, and you may want to avoid anti-HER2. This is what the NCCN says, intensive therapy not recommended, and this is there. But from the second line onwards, all sorts of HER2, including Destiny CRC trial is there, and you can use that for your patients. So the last to conclude, MCRC has evolved a lot in biomarker space. NGS, if patient can afford, should be done either upfront or from rapidly progressing metastasis on progression. You cannot decide your treatment based on the first NGS when the patient has already received 2 lines of treatment and you are deciding the third line based on first NGS. No, that will not work. RAS wild type, RAF wild type, left side, anti-EGFR plus chemotherapy should be the option. RAS wild type, but RAF mutation and left side, encorafenib plus cetuximab can be the option. Keep looking out for IO addition. Right-sided tumor in RAF mutation, try to use bevacizumab plus FOLFIRINOX if the patient is fit. MSI high, IO or IO plus IO, irrespective of the left and right side. MSI high but RAS mutation, try to avoid IO. MSI high but RAF mutation, you can consider IO. HER2/neu amplified, more than 8 copies. Remember, anti-HER2/neu can be considered from second line onwards, and first line if the patient is not fit or waiting for chemo. And CFDNA is a very interesting space, and we have to keep looking out for more data. With that, thank you, Dr. Bajaj, for giving me this opportunity. It was really an enjoyable experience.
Thank you, sir. The pleasure is all ours. And as many people are saying on the chat, a very nice talk, and all of us really enjoyed it. Just one question: liver-limited disease, 3 liver metastasis, and it is a EGFR. Sorry, the RAS-RAF is wild type, and it is a left-sided colon. What would you like to do? Would you like to give cetuximab in this patient? Right side. I said right-sided. So right-sided, wild type, liver-limited.
Right-sided. Rajat, there is a very interesting today for one of our patients. I was talking to one professor, I forgot his name, Edreka or somebody who is a GI expert in Europe. He showed me an interesting data in 2012 and 14 and 16 that in fact in a liver-limited disease, if you don't use either cetuximab or Bev, either before or after surgery, patients live longer. It's very, very interesting. I would, tomorrow I think his talk, and I will try to attend that. In the right side, right now, I'm not using anti-EGFR. Okay. The left side, yes, I'm using, but right side, I'm not using anti-EGFR in the first line. And this is again a paradox. Second line onwards, you can use anti-EGFR, but the first line you can't use. So I'm not using it.
Yes. Right. Thank you so much. So there are many questions, but then in the interest of time, I'll have to stop here and hand over the mic to our next speaker, Dr. Shyam Agarwal, sir, who's back with us. Sir is going to talk about the role of ICI in colorectal cancers. Is it ready for prime time? Over to you, sir.
Right. So thanks, Rajat, for this second talk. So I think the more important question is if the patient on the right side is MSI high, so what would you be doing then for liver-limited disease, Amish, are you there?
Yes, sir. Yes, sir.
So what about immunotherapy as compared to induction chemo, with or without Bev or whatever you think?
Sir, we'll discuss with patient. NCCN says it can be used. I would discuss with patient. I am CRC, MSI high, very good data, sir. Of course, this is all in the unresectable. But sir, hardly anybody has relapsed after 2 years.
Great. So I think those are the questions which are emerging now with the availability of immune checkpoint inhibitors, and seeing very, very robust responses in patients who are MSI high. However, as you know, in colon, as I discussed in GI, the MSI high status is is rather low in terms of its incidence. So I think I'll just, a lot of things have been said by Amish. So I'll just, close in a few minutes. I'll just cover the relevant slides. So these are the headings in which we will sort of discuss these issues. So I think, as we know, the MSI in colon cancer is seen in about 15%. Next slide, I think, is going to highlight that problem is that if you go to the metastatic setting, it comes down to 5%. And that is where the drug is possibly, most effective. And these are certain subtle differences in the biology of MSI high and the chromosomal unstable kind of disease, which is much more common. So the problem is, you will, in your practice, be very lucky to find a patient with metastatic disease who has an MSI high tumor. So next slide. So I think I'll just cover this point subsequently, that we need to do the test. So next slide. So this is the other issue, I think, which was, I think Dr. Amish covered, which was the mutations, a number of mutations per tumor. So as you can see, the colon is again, if you look at the sporadic adult solid tumors, again, you don't find too many patients with high tumor mutation burden. Next slide. So this is what I just said. MSI is 5% high in metastatic colorectal cancer. Mostly it is MSS. And this is what I was alluding to when I, in the previous talk. So it is not only MSI high with the high immunoscore, but even if somebody has MSS but has a high immunoscore, so these are the patients, who tend to perhaps benefit or have a better outcome in terms of prognosis. So I think as I was discussing in the stomach cancer or the upper GI cancer, adenocarcinoma, so you need to have some kind of score which could identify these patients who are eligible or who could benefit from these, simple, safe, although expensive immune checkpoint inhibitors. Next slide. So I think that is how the thing has evolved. As you know, this is the NEJM publication where solid tumors with, MSI high showed the benefit. And if you were to look at the colon cancer patients, which is in the blue bars here, so they really, benefited as opposed to the proficient MMR. Next slide. So I think this is the same slide where you can see the response rates 52% and a disease control rate 82% in colorectal patients. Next slide. And a similar benefit was seen irrespective of the tumor type. And as was being pointed out, so they really have overall survival, which is not reached. Next slide. So that's the beauty of these immune checkpoint inhibitors. And not only for pembrolizumab, so this data has also been shown in the pre-treated patients in second or subsequent lines with a combination of Nivo, Ipi, and however, Nivo alone doesn't seem to give you the benefit. Next slide. And that is the Nivo Ipi, which is seen here, giving you the benefit as you saw with pembrolizumab, and overall response rate of 55%. Next slide. So this is the other drug which has also been approved, which is the dostarlimab. And again, you can see response rates to the tune of 50%. And this is approved in August 2021. Next slide. So I think with this, the NCCN guidelines, as was shown before, Nivo, Ipi, or Pembro is approved in patients with deficient MMR or MSI high alone, and in the first line. So and patients who have not received therapy. Next slide. So I think it is as was shown before. So since we are running really short of time, I'll rush through. So I mean, this is now coming to again. I think this data I've already shown. We'll just skip these slides. Next slide. Next slide. I think. So now coming to the first line. So second line, of course, the data is approved. But I think in the keynote 177, Pembro showed the benefit. Next slide. So I think these curves are really self-explanatory, and everybody is aware of these curves for PFS1 and PFS2. Next. And again, the overall survival, fantastic. You see the response rate in the first line of 70%. Next slide. And you see similar positive outcomes with the combination as you saw in pre-treated patients. And this is the first line data. Next slide. And so I think both these combination and the single drug of Pembro is approved. So then, if you have a patient whom you have not treated before with immune checkpoint, so there is data for two combinations. Next slide shows you Nivo with regorafenib, and you can expect, and this is again, you see for proficient MMR or MSS CRC, especially patients who don't have liver metastasis, one can expect a response rate of around 21% and a median duration of stable disease for 30 weeks. So this is a combination which one can think of using in your patient who are really desperate after the failure of chemo. Next slide. And the LEAP study, which had Pembro and lenvatinib, again gave you a similar kind of a response rate to the tune of 22%. And a duration of response not reported, but the overall survival around 7.5 months. And these are heavily pre-treated patients. So I think Lenva Pembro is also a viable option for such patients in CRC who are proficient MMR. Next slide. So I think you can see these looking at the response rates. Next slide. So I think this has become so very important now, as was highlighted before, that all patients, before they enter into chemotherapy or for systemic therapy, they must undergo the testing. Next slide for MSI or mismatch repair. So I think these are the guidelines at this point in time that you have to have universal slide. Next slide, please. I think just states that you have to have MMR or MSI testing for all newly diagnosed patients with colon cancer. Next slide. So just a word about the testing. So you have two methods for testing: PSR-based tests for MSI, and IHC is looking for loss of expression for one or more of the MMR proteins. So one can do either of them. Next slide. And I think next slide, please. So I think the IHC based test is looking at the MMR protein, and the PCR on the tumor DNA is looking for the MSI. So they are both sort of synonymous. So a deficient MMR is synonymous for MSI high, as you all know, and proficient is synonymous for MSS. So I'm not going to the details of this. Next slide. So I think IHC for MMR and the PCR for MSI is kind of equal, and one can do, this is the more widely prevalent, but this you can do by PCR or by NGS testing. Next slide. So I think the next slide, please. So I think these are all, so I think as I mentioned. So next slide. So neoadjuvant studies. I think this is an important area of research, as was, I think, earlier touched upon by Amish. So this is for dostarlimab, a short, small number of patients, 13 here. And this is done for MMR defective, which is MSI high, rectal adeno. Next slide. And interestingly, as was seen before, and you will see in the next slide, 100% patients had, an overall response rate, and a complete clinical response was achieved in 100% of patients who completed the induction treatment. So this is extremely encouraging, data for, but the problem, as I showed you, is that the number of patients you will get will be few. Next slide. So this was the, so I'll skip this. Next slide, please. Yeah, so this is from Chalabi et al. For neoadjuvant immunotherapy in MMR proficient and deficient. I'll just read the abstract. Next slide. Next slide, please. Yeah, just show the previous slide. Yeah, the previous slide, yeah. So if you see focus here, so if you, I mean, they had 40 patients, odd patients, and 20 were deficient MMR, and 15 were proficient MMR. So if you look at the pathological responses, 20 out of 20, and in the deficient MMR, 19 major pathological responses were seen. So this is very, very encouraging, in contrast to proficient MMR, where only 27% patients had responses, and only 3 out of 15 had major pathological responses. So I think the data for colon cancer also is extremely encouraging for neoadjuvant therapy, which one could consider doing, but I think more trials are needed in that direction. Next. A word about pseudoprogression. This is again from Andre et al., where they reported. Next slide. Nearly 30% patients, or some patients who reported pseudoprogression at 5.7 weeks. So the median time for pseudoprogression was 5.7, and so you really have to be careful. And can I have the previous slide? So I'll just read the last line. Patients with MSI, they experience pseudoprogression. It occurred within the first 3 months and represented most of the primary radiological progressive diseases. And the use of iRECIST criteria should be questioned after 3 months. So I think this is important to understand, that I think we sort of tend to ignore if the patient is doing well for pseudoprogression. Next slide. However, the other study, which is Nivo-IPI, next slide shows that they did not. It's very rare. Pseudoprogression is very rare. when they use Nivo EP. Next slide. So these are some of the miscellaneous slides to show, I think, which is what Dr. Amish was referring to, that patients, if they have BRAF or RAS, they don't tend to get that much benefit as compared to patients who are MSI high. So I think this is the confounding factor for the responses to immune checkpoint inhibitors. I think the subsequent slides are, next slide, are covering, so I'll skip this. Next is the potential of trying to do MEK inhibitors like cobimetinib along with atezolizumab. So I think people are trying various combinations, as I showed you, for LEAP study and for regorafenib. So I think people are trying to look at various combinations with immune checkpoint inhibitors. Next slide. So I think I'll just skip these slides in the interest of time. So this is the other thing which was being referred to, which was the tumor mutation burden. And next slide shows that patients with the colorectal cancer, I mean, you can see colorectal cancer. So the median, TMB is around 11 or so. So these are candidates, but if you look at the endometrial, I mean, they are the best responders. Next slide. So it's a tumor agnostic marker, especially if the TMB is more than 10, although the data, some people say it is more than 16 or 20. So this is the relationship between MSI, TMB, and PD-L1. As you can see, TMB is high in 8.1%, MSI is unstable in 3%, PD-L1 is positive in 17.6%. So I think you do have a small group of patients who could be having high MSI or high TMB who tend to benefit from PD-L1 has not really, beneficial alone by itself. So I think the last slide. Yeah, so I think we are there. MSI high, if the high tumor mutation burden is there, it can predict responses to checkpoint inhibitors, and the NCCN guidelines for MSI high and TMB high are there. And not only approved in second line, but also approved in first line now. Combinations are approved. So I think the new combinations are still being evolved, whether it is with chemo or in the neoadjuvant setting or with the other MEK inhibitors, etc. So thanks a lot.
Thank you so much, sir. A lot of it will be discussed more in the ensuing panel discussion. And now we go on to the panel discussion. This panel discussion is going to be on the ideal first-line sequencing, the ideal sequencing of management of metastatic CRC. And to do this panel discussion, we have with us Dr. Atul Sharma, sir. Sir, good evening. Sir, as we all know, is the professor in the Department of Medical Oncology at AIIMS Delhi. And he is going to moderate this panel, and we have an eminent panelist list with us. I'm going to call all the panelists. Dr. Ghanshyam Biswas from Bhubaneswar. I can see him, he's there. Dr. Nidhi Tandon from Bangalore. I think Dr. Nidhi has joined already. Dr. Arun Chandrasekharan from Calicut. Dr. Amit Dhiman could not join, unfortunately. Dr. Venkat Pradeep Babu from Assam, I think he's also there. Dr. Atul Sharma, sir, over to you.
Hi, good evening. So I don't know Amish is there around or not, but after listening to Amish and Dr. Shyam Agrawal, I don't think that we have any confusion with regard to this thing. Hi, Amish. Good to see you.
Thank you, sir, for the kind comments. But we love to hear your comments, sir. So I'm there.
I'm just trying to probably cover a very few points, because most of these have been an interest of the time, maybe some other time. I was just traveling, just reached home from Jaipur. And can somebody show the slides? Hi, Ghanshyam.
Hi, sir. Good evening.
Good evening. Yeah. Okay. So basically what I have been instructed, the mandate is that we discuss mainly the first line and mainly on the left side of this thing. So I think I didn't try to interrupt too much about these things, slides and this thing. But I probably, in case the audience is still around, probably would love to have extempore some question from the audience rather than what has been prepared. So basically we are trying to, can we move on to the second? Welcome all the panelists. So basically the idea is to choose right treatment. It's not right side, but the right treatment sequence in left-sided RAS wild and BRAF wild type metastatic CRC. And I believe most of the time when we discuss this thing, these are the bases which are not considering the unresectable, which are not considered resectable tumor. So that we try to discuss 2 or 3 questions important, and since we are the 4 panelists, will take their opinion. Can I have the second next slide, please? So basically important question which Amish also alluded to and probably did show algorithm and the sequence also. What influences the treatment choice in metastatic colorectal cancer? Which sequence is preferred and why? Basically, when I say sequence, this does include chemotherapy as well as targeted treatment. And Amish and Dr. Shyam Agarwal did cover some part of the patient with MSI high tumor. So probably we can go to this thing. So Ghanshyam, since I can see you, so what influences the treatment choice in metastatic colorectal cancer?
So left versus right, fitness of the patient, and at least the 5 markers like the MSI PD and the HER2/neu, BRAF, and the all-RAS. So this is going to be my baseline for any systemic therapy with or without targeted therapy for a metastatic colorectal.
All right, since you did you say about the HER2/neu as well?
Yeah, sir. I'm 5. So
okay.
KRAS, NRAS, HER2/neu, MSI.
Amish, for the first line, since you are still there, and so what is your opinion about the first HER2/neu in the first line setting?
So we do not have enough data where it has shown that in the first line compared to chemotherapy and targeted, it has shown overall survival benefit. So even if you see NCCN guidelines, they clearly say that if the patient is not fit for intensive treatment, then you can consider the combination of trastuzumab plus lapatinib in the first line. Otherwise, second line onwards, all anti-HER2 can be one of the options.
Sir, I will add to what Amish said, because if you pick up an HER2 overexpressed or a mutant, so probably your anti-EGFR choice won't be there. So that's another point.
Okay, so we do most of the time, like, can we move on to the second slide? So basically, what are the important, Ghanshyam has said that the RAS, BRAF, MSI, tumor location, of course, is very, very important. And I did not highlight the HER2/neu in the first line because probably most of the time, I would say at least that probably it becomes, we are not having adequate data to use any HER2 targeted treatment in first line. And of course, Ghanshyam did allude to about the patient characteristic, this thing, comorbidity, age, first previous treatment. But the important point which Amit also highlighted and Ghanshyam reiterated that we need to have this thing RAS, BRAF, and MSI status known in front of us for any patient. And of course, tumor location is very, very important factor. And we know. So Dr. Nidhi, what is your opinion about tumor location? So do you feel that this is more common left side, or do they do better than the right side? What is your opinion? Is Nidhi around?
So right side usually appear to do worse than the left side, and they are more commonly found to have mutations of RAS and BRAF. So and of course we prefer to use EGFR targeted therapy in left-sided tumors.
Okay, can I go to the next slide, please? So of course, now we have the ample evidence which suggests that the whatsoever the reason may be, the bottom line remains that the left-sided tumor do better than the right-side tumor. Of course, Nidhi did say that they have a lot of poor prognostic factors, probably in the right-side tumor, and we have more EGFR, this MS, height TMB on the left side. They are these. So of course, the bottom line is that the left-sided do better than. We have a number of evidence for that. Can I go to the next slide, please? Next one or two. Of course, the various guidelines, whether this is NCCN, ESMO, or ESMO Asia, everything suggests that they probably the right side tumor do worse than this thing. So, Dr. Venkat, the important question: does treatment sequence matters? If yes, what should be your choice for that? We are discussing the left side tumor, BRAF wild type, KRAS wild type. What should be the first line choice, second line, and probably so on?
Good evening, sir. So So the main determinants of sequencing are the molecular mutations, which we do and the results of the test. So if it is KRAS wild type, definitely targeting EGFR has shown better outcomes in left-sided metastatic tumors. So chemotherapy plus EGFR target therapy antibody is the will be my first choice. Sir. So after that, depending upon the response and duration of response, I will choose my second line therapy. Sir.
So a follow-up question to these things. When you say EGFR plus chemotherapy, do you have any particular chemotherapy protocol in mind, or what are the factors based on which you decide the chemotherapy should be used?
In a patient who hasn't received any previous therapies in adjuvant or other settings, definitely oxaliplatin and 5FU-based chemotherapy will be my choice to combine with antibodies.
Any specific reason for that? Do we have more evidence with the oxaliplatin-based chemotherapy? Or
no, sir, not at all. But there is no particular evidence that FOLFIRI or FOLFOX will do better in the first line. So there is no particular.
Patient is treatment naive, unresectable metastatic colorectal cancer with the RAS wild type, BRAF wild type. So Ghanshyam, any particular combination?
So evidence is more because if you look at the trials, so the oxaliplatin trials were more than the irinotecan in the first line.
In fact, the first trial was the crystal trial using the FOLFIRI.
But subsequent to see most of them were 60% have received actually, if you put together all first line, so they are oxaliplatin based. And most of them were US based trials.
Amish, you want to comment on that?
Sir, Americans use FOLFIRI a lot. But as Ghanshyam said, many of the academic institutes use FOLFOX. The only problem with FOLFOX is neuropathy. And second thing, nowadays, a lot of that oxaliplatin can modulate the microenvironment for future treatments. But sir, I use FOLFOX more commonly because it is easily tolerated and there is no hair loss with FOLFOX. So as a result, people take it very nicely in the first line, sir.
All right. So I have little difference of the opinion, and then probably what I say that of course I agree that it doesn't cause alopecia or this thing. But personally, I think that FOLFIRI is better tolerated than FOLFOX. The simple reason being that after a couple of cycles, probably they end up having either the neuropathy, and then probably either you reduce or compromise the dose or this thing. But I agree and concede that no data which suggests, in fact, that trial has clearly showed that whether you use FOLFOX, FOLFIRI or FOLFIRI, FOLFOX doesn't make much of a difference. So I agree to that. Next slide, please. Of course, we don't need to discuss this question. If there is a left side tumor, RAS and BRAF wild type, probably obviously everybody will be using the EGFR inhibitor. Anybody wants to take a question whether it should be the cetuximab, or is there any difference between the cetuximab or panitumumab?
So most of the trials are with cetuximab, so that's why. So probably we are mostly accustomed with cetuximab.
Toxicity, personal experience, toxicity.
So for personal experience, the toxicity probably for me, so panitumumab was more toxic than cetuximab.
Is it?
Yes, sir. Though
does it have the similar experience? So it is chimeric versus this immunized, so probably it should be the
other way, right?
Yeah, Nidhi, do you want to comment on that toxicity, EGFR inhibitors?
So this actually, as you're saying, it should be the opposite, but my experience also has been like Dr. Ghanshyam Biswas, and I also found panitumumab to be slightly more toxic than cetuximab. But also because of the cost issues, I prefer to use cetuximab rather than panitumumab, sir.
Okay, cost is almost the same. There's not much difference between the cost, I believe. Anyway, I hope the first slide which showed this mark probably is not influencing our Anyway, the other point I probably would like to highlight is that the most protocol probably using this thing, cetuximab, standard or approved indication is weekly, though we do use every 2 weeks. whereas the panitumumab is every 2 weeks anyway. Next, please. So this is the data which suggested that there are 2 meta-analysis. In fact, there is a third one also which says that if we use probably for in the given situation, everybody will be using EGFR inhibitor first rather than the VEGF inhibitor. So we don't need to discuss that. Next. This again is another pooled analysis suggesting the same, that if you use cetuximab first or EGFR inhibitor first, you get the survival advantage. Next one. I can skip all these things, and the last questions to all the panelists. If you have a basically treatment naive, like Amish probably did discuss about this, RAS wild type, BRAF wild type, and also having the high TMB, Dr. Shyam Agrawal says high TMB, or if you want to believe in the MSI, high MSI. So what will be your choice of treatment? RAS wild type, BRAF wild type, high TMB, and MSI high. First line.
Sir, MSI high.
So MSI high, RAS wild type, BRAF wild type. So you have more than one choice.
Yes.
And the TMB also high.
So definitely immunotherapy, sir.
Everybody?
Immunotherapy, sir.
Which is in?
I still go for chemo plus targeted therapy, and I will save the immunotherapy for the later lines, because I think sequencing do matter. That is my personal opinion, sir. I do not have any pressing evidence for that.
Dr. Shyam, since you are still there, you are sending a comment. I think so. You will go for the immuno checkpoint, or?
I raised that question. So you put it on the left side where you will have the best evidence for EGFR drug and chemotherapy. So I think since the approval is there for metastatic disease in the first line for MSI high, so I think it's all right to use the immune checkpoint.
Perfect. So I agree that both are valid options. This thing. So Amish, you were covering this part and this thing. So do we have evidence suggest that if you use checkpoint inhibitor first line and then subsequently if you want to use the EGFR, do you have any problem or any less effectiveness of the EGFR inhibitors or more toxicity or this thing?
Sir, Keynote 177 was a randomized study between immune checkpoint inhibitors and chemotherapy. And the median duration has not reached in the immune checkpoint inhibitor as regards overall survival. And you see the PFS gap in the PFS1 and PFS2. So PFS2 clearly means that after immune checkpoint inhibitors, either anti-EGFR or BEV are used. I have no doubt in my mind that if BRAF is wild type, RAS is wild type, MSI high and TMB high, I would definitely use immune checkpoint inhibitors, unless and until there is a trick question put by you, sir.
No, I won't put it.
What will you do, sir? Since you allowed us to ask you question.
Yeah, obviously. So I probably will, in case the funds are available and probably everything is available, then we'll go for this thing checkpoint inhibitor.
So what about, sir, MSI high? Every situation is same, but the TMB is low.
So Dr. Shyam Agrawal did show a slide, I believe.
Yeah. So there is a difference between a high TMB and a low TMB. But if it is a given situation, then chemotherapy
is based on the MSI high.
Yeah, Ghanshyam, I think TMB doesn't really, to my mind, would make a difference. If the MSI is high, so I think the immune checkpoint inhibitor will score over chemotherapy and your targeted drug, especially if the RAS, RAS obviously is wild type,
right.
And especially if the BRAF is also wild type. So I think the data is quite strong and compelling. I mean, you have a response rate of about 70%.
Durable, correct. And durability also.
Correct, yeah.
All right, probably I think in the interest of time, probably we'll stop this panel discussion. I thank you everyone. And also a special thanks to Dr. Shyam Agrawal and Dr. Amish Vora for joining the panel. And thanks to Dr. Rajat Bajaj. Thank you, everyone.
Thank you, sir. Thank you so much.
Thank you, sir.
Okay, thank you very much.
Thank you, Dr. Atul Sharma, sir, and I thank all the eminent panelists. Special thanks to Dr. Vora and Dr. Shyam Agarwal, sir, for staying back for the panel. Very insightful discussion on how to really go ahead treating metastatic CRC patients in the current era, especially with the many biomarkers that we have now and how to really sequence them. So with this, we come to the end of day one of this update series that we are doing over 2 days. So tomorrow we are going to talk about the updates in lung cancer, and we'll start at 6 p.m. And I thank all the attendees who have stayed with us for the last 3.5 hours. It is approximately 9:20, and we have good number of participants even now. So thank you so much once again, all the panelists. I thank my organizing team members, Dr. Venkat, Pradeep Babu, and Dr. Chatur Buj for organizing this event. And we'll see you tomorrow at 6 p.m. Thank you and have a great evening ahead.
Good night.
Good night, sir. Thank you, Dr. Bajaj.